direct our noble cause, guide our leaders right, help our youth the truth to know, in love and honesty to grow, and living just and true, great lofty heights attain, to build a nation where peace and justice reign. Please sit down. Thank you very much. My name is Taribio Walson Owefawari. Is a long name, sorry. My co-MC is ABRV, and together we'll try our best to make sure the program moves smoothly. Today, this is day 2. We have at 9 a.m. I know we're running a bit behind schedule. We have poster and oral presentations. Then we have the second plenary. And then we have parallel 1. The parallel 1, we have room 1, room 2, room 3 upstairs. They will be running concurrently. So please, once it gets to that time, we'll move to formally introduce the chairs and tell us what the poster and oral presentations are all about. I would like to invite Dr. Adedotun Adeshino. He's a public health physician and member scientific subcommittee of the Bayelsa Health Summit. Please put your hands together for him as it comes to the stage.
Good morning, everyone. So we are welcome again to day 2 of the Bayelsa Health Summit. And to kickstart the poster and the oral presentation, the chair of this session is the consultant public health physician, is the head public health department of the Federal Medical Center, Yenegua, and is also the head of the CME committee, Nigerian Medical Association. Join with me as we welcome Dr. Eguve to the high table. Please, let's put our hands together for him. And to co-chair this session with him is another community health physician. You know, yesterday we kept on talking about community. So we have another community health physician, Dr. Oguche. She's a public health physician with the Federal Medical Center, Yenegua. Please, let's put our hands together as she comes to the table. And the rapporteur for this session is Dr. Anosike Sotonye. Please, let's put our hands together for her. The presenters, we are going to have 4 presentations this morning. And the presenters are Dr. Neni Awurabioki. Let her come forward. The second presenter is Dr. Agnes Alade. Let's put our hands together for them, please. And the third presenter is Bamidele Odushote. The fourth is going to be, the fourth presentation is going to be a presentation by WAPCO. And so we're going to have the oral presentation now. And okay, so let me hand over the mic to the chair of the session. But I am Dr. Adeshino again, and I want us to get our questions and things ready as the sessions are going on. I'll be collating all that. Thank you very much.
Thank you very much, Dr. Adeshino. Good morning, everybody. You are welcome to this plenary sections. We are going to have several presentations in this session and oral presentations, which will be taken first. After the oral presentations, we will now go out for poster presentations. As a way of ground rules during these presentations, the presentations will be taken first. All the presentations will be taken back to back. After all the presentations, we will now take questions. So it's important that we share pieces of papers around for members to please note their questions as the presentations are going on. At the end, we take the questions. The presentations are going to be very short. They're going to be maximum of 8 minutes presentations. Thank you very much. We are also going to, as I said, the poster presentations after the presentations. Without much ado, I will give it to my co-chair. Let her introduce the first presentation.
Good morning, everyone. Welcome again to our oral presentation. Our oral presentation is availability of malaria prevention and treatment services and its delivery among public health facilities during the COVID-19 pandemic in Bayelsa State, taken by Nene.
So we welcome Nene Aworabi. Let's give her a round of applause, please.
Good morning, everybody. As he has introduced me earlier, I'm Dr. Neni Aworabi Oki, and I'll be taking the presentation on the availability of malaria prevention and treatment services and its delivery among public health facilities in Bayelsa State, Nigeria during the COVID-19 pandemic. Next slide, please. The presentation will take the following outline: introduction. Thank you. Introduction, methods, results, conclusions, and recommendations. Next slide, please. As a form of introduction, we are all aware that the COVID-19 pandemic took the world by surprise. And in the wake of the pandemic, different activities and health-related interventions were disrupted. The impact of the disease has overwhelmed most health systems, and it makes it worse when a disease like COVID-19 has similar presentations with malaria. COVID-19 and malaria presents with fever, difficulty in breathing, body pains, and similar symptoms. So the aim of this study was to determine if the COVID-19 pandemic had affected malaria services, also to determine the availability of the services during the pandemic. Now, globally, malaria has been picked for elimination, and it is important that countries maintain the prevention and treatment services that are required to ensure that we attain that level globally. The study will serve as a guide to identify the gaps in service delivery and training in the state, and hopefully organizations and partners that are present will cue into this gap and support the state in terms of closing the gaps.
Next slide, please. Who is in charge? Please change to the next slide or do something about it. Yes,
okay, so we know that COVID-19 pandemic and the measures put in place, such as self-isolation when you have fever, restriction of movement, have come to affect malaria treatment. From the National Malaria Immunization Program, every case of fever should be tested. But with self-isolation and restriction of movement, many people did not go to the health facilities when they had fever. Many activities such as malaria distribution campaigns and long-lasting insecticide nets distribution campaigns were all distributed. Even supply of malaria commodities were also affected because of the COVID-19 pandemic. Sorry, my slide is not coming up. So the study was conducted among public health facilities in Bayelsa State. We did a facility-based cross-sectional survey. Facilities that were owned by the government and that had been functioning for the past 6 months were included in this survey. We surveyed 127 health facilities comprising of primary health centers, secondary health centers, and the 2 tertiary health facilities in the state were studied. The methods we applied, we looked at service availability and we looked at service readiness. For service availability, we looked at the presence of health infrastructure. We looked at the presence of workforce, manpower. We looked at bed adequacy. We looked at time that the health facility was open up to deliver services. Then in terms of service readiness, we used 5 domains to decide service readiness using the WHO SARA service availability and readiness tool. And then we combined it with the National Malaria Elimination Guidelines to form our checklist. 5 domains were looked at. We looked at the presence of trained health personnel. We looked at the presence of trained health personnel for case management, trained health personnel for diagnosis. We also looked at the availability of national malaria treatment guidelines in all the health facilities. Every facility treating malaria ought to have the national malaria treatment guidelines. We also looked at diagnostic capacity in the terms of availability of a microscope or RUDT. Then in terms of commodities and drugs, we looked at the presence of unexpired ACTs in all the health facilities. So what did we find out? From our results, we discovered that only 45% of health facilities in Bayelsa State, ranging from 12.3% in Ekeremo and 83.4% in Yenegua, were classified to have service availability. Then for the readiness, it was observed that only 14.2% of facilities in Bayelsa State were ready using the 5 domains that we used to do the assessment for malaria prevention services, with BRAS having no facility being available and Yenegua having just 25% of the facilities having been ready for malaria treatment. So also, we looked at the cases of fever and malaria. We used the pre-COVID period of 2019 and the COVID period of 2020. We're all aware that the first case of malaria, the first case of COVID-19 in Bayelsa was diagnosed on the 29th of April. So our study looked at 4 months after the first case of diagnosis, May, June, July, August in 2019, and May, June, July, August in 2020, corresponding months. We looked at the number of cases that came in all the health facilities presenting with fever, and we looked at the diagnosis that was made for malaria and compared it with both pre-COVID and during the COVID era. From our findings, we found out that there was a 41% reduction in the cases of fever across the state compared to the 2019 period. So we also looked at the predictors. What are the predictors of health readiness? So we imputed our variables in a binary logistic regression. And the only thing that was significant was that health workforce and the location of the health facilities, those facilities that are located in the rural areas were more likely to be ready than those that were located, in the urban areas, were more likely to be ready than those located in the rural areas. And those facilities that had adequate workforce in terms of a trained clinician to handle case management, a trained microscopist, and other features were more likely to be ready to offer malaria treatment services in Bayelsa State. So what were our conclusions? We concluded that the state needs to do more to ensure that facilities are ready for malaria prevention and treatment. And during pandemics like this that have similar presentations, we do not want other medical conditions to suffer because of the other condition. For instance, we are aware from our results, there was a 41% reduction in the malaria cases that were confirmed in 2020 as compared to 2029. This is not in keeping with our aim to achieve malaria elimination and maintain the global standard. So it is important that the government to undergo a community sensitization and mobilization of people. And when measures are put in place to prevent spread of pandemics like the COVID-19, we should also put in mind that other health conditions are also in existence and should not be ignored. So we are also realized that the COVID-19 pandemic further reduced the populace demand for malaria health services. So that is what informed our recommendations. Thank you.
Thank you very much, Dr. Awurabi Oki, for a very wonderful presentation, even in the midst of technical challenges. Let's give her another round of applause. We are going to take the next presentation immediately, and this presentation is going to be taken by Dr. Agnes Diprebi Alade. Please, let's welcome her to the stage. She's going to talk to us about a study on the evaluation of service quality in primary and secondary health facilities in Bayelsa State. Welcome her with a round of applause. Thank you. Your presentation is maximum of 8 minutes. Please let them put up the slide and you continue. Okay. We are still having some technical issues and they are still setting up. So Dr. Alade, please go back to your seat. Let's just take questions from this very first presentation. Let's signify by raising up our hands. Let's just take the questions for this first presentation. Is there a mic you can use to, questions and comments, please? Okay.
Hello.
I think that.
Is there any question or comment from the first presentation?
Hello.
Okay, just please pass the mic.
A hand is up at the back. Okay, 2 hands even.
Let's take 5 questions and we'll go. Thank you. Dr. Awurabi, please take note of your questions. Okay, question.
Hello.
Hello? Yes, I am Odoko Joseph. Your work is good, and we are in the era of prevention. And especially malaria has been another target that's been worrisome. And my question is, what role or strategy are expected from community health workers in the prevention of malaria in the rural areas of Bayelsa State and Nigeria in general? The second question is it possible from your research to eradicate malaria cases in Nigeria? If possible, what role is expected from the government, community health workers, and environmental health officers? Thank you.
Let's take the second question.
My name is Douglas Tamnomiabi. Nice presentation. I have 2 questions to ask you. First is, your data. How was your data gotten? Is it randomly across the 8 local governments to present Bayelsa State, or it's basically in the facilities in Yenagua? Then the second question is public health facilities. Like you mentioned, I know one basic public health facility is the community pharmacy. And we know that in Nigeria especially, the first point of call is the community pharmacy. What is the role of the community pharmacy in what you have presented? Thank you.
Any other question, please?
Yeah, my name is Matthew Akwebi, DSNO Sabama. I've heard the presenters talking about manpower shortage as a major concern. So my question is this. Now that you've discovered from your survey that there is manpower shortage, especially the clinician, to mount the primary health care, what were your recommendations? Thank you.
Okay, sir, we have about 2 more.
Okay, 2 more questions and we'll stop there. She responds to the questions and we'll move forward.
My name is Possible Ominigbo. That was a wonderful presentation. I have just 2 questions here. My first question goes like this. Concerning your instruments, how did you validate your instrument? That is my first question. My second question is, how did you analyze your data? Because I didn't hear you talk about this thing. Thank you.
1 more.
Okay. Okay, thank you very much. Let her 1 more questions, okay? That'll be final.
Good morning, everyone. I'm Okpako Esther. Thank you so much, Dr. Aworabi, for your presentation. I just wanted to ask, you said that the study recorded a 41% reduction in the malaria services or need for malaria services. So I wanted to know whether you considered the fact that during that period, there were lots of reduction and restriction of movement as a reason for that 41% reduction in your services. I don't know if it came anywhere as a limitation, but because I think it should have played a role.
Thank you very much. Let her respond to our questions and comments.
Thank you
Please
for all your questions and comments. I think I'll start with the last question. If you, for my recommendations, I said that when we have pandemics in this manner, government should be aware that when diseases that present those similar, there's a possibility that those other diseases will be neglected, which is exactly what we saw here. Then I also made mention that measures that were put in place to prevent and contain COVID-19 affected malaria in terms of self-isolation when you have fever. So people did not go to the facilities. So that could actually account for that 41% reduction in cases around the state. Then for the fourth question, it said that what instruments we use? We use the WHO certified SARA, service availability and readiness instrument that is already in existence, combined it with the National Malaria Elimination Plan checklist and created one instrument which we use to go around the facilities. That checklist was validated by a malaria specialist from the University of Ibadan, and also the malaria program manager in Bayelsa State looked at the questions and we did a sort of validity with that. Then in terms of data analysis, we use Microsoft Excel, and then we used SPSS to do the analysis to get the results. Then our information was also put on QGIS software to get the facilities that had malaria service availability. Then in terms of the person that asked about what we are going to do for health manpower deficiency, I believe that's why the summit has been called forth, so that we can share ideas on how we can get adequate manpower in our health facilities. Then for the data technique, we actually did a multi-stage sampling technique where all the health facilities in the state were selected. Then using our sample size, we did a proportionate sampling for all the tiers of health facilities. For primary health centers, secondary health centers. Then the only two tertiary facilities in the state were studied. Then you talked about government-owned. So because I did not have that full presentation, one of the inclusion criteria is that it must be a government-owned facility, not pharmacists or chemists. But I understand that many cases of malaria actually go to these facilities, so it's something that should be looked into. Then for the role of community health workers in the prevention of malaria cases, community health workers are the backbone of disease prevention actually in Nigeria, because they are the first point of contact with the people in the community in terms of health education, in terms of carrying out the interventions for malaria prevention and other diseases. The community health workers are key. Thank you very much.
Thank you very much, Dr. Awurabi. Let's give her a round of applause. Very articulate response to the questions. I think we are ready to move forward. We are going to take the second presentations right away. And it's going to be taken by Dr. Agnes Diprivi Alade. The title of our study is Evaluation of Service Quality in Primary and Secondary Health Facilities in Bayelsa State. Let's welcome her with a round of applause.
Okay. Good morning, ladies and gentlemen. I'm Dr. Diprivi Agnes Alade. From Bayelsa State Hospitals Management Board. I'll be doing a presentation on evaluation of service quality in primary and secondary health facilities in Bayelsa State. Now, our question is, why do we evaluate service quality? We evaluate service quality because we want to improve desired health outcome. Now, quality of service is that degree of health service rendered to patients or population that will increase the likelihood of a desired health outcome. And when patients have a good health outcome, invariably the economic situation of the states and the country at large will be improved. We also want to evaluate service quality because it's a prerequisite for improving quality. We want to standardize quality, we assess quality, we evaluate quality. If we don't evaluate quality and find out what the problems are shortfalls, we won't be able to improve on it. So it's also a reason for it is a prerequisite for improving quality. To achieve this, health quality has to be safe, timely, efficient, effective, equitable, and people-centered. Now I'll be doing my presentation using the following outline: background, aim and objectives of the study, methodology, results, discussion, and conclusion. Now, as a way of background or introduction, I had already mentioned that we evaluate service quality because it's a prerequisite of improving quality. We want a standard that we can work on. Now, measuring health, as I said, is a prerequisite for improving quality and provides objective guide for policymakers, for stakeholders to improve that help the health sector. Now, how do health workers evaluate service quality? Health workers evaluate service. Health workers evaluate services provided from what they perceive should be the optimal in providing services. For instance, you have a rural health center and a patient presents with a gunshot injury. If the health worker has all the things available to attend to this patient, it perceives his satisfaction. The patient, on the other hand, perceives satisfaction or service quality as what they receive, as what they gain from the service, as what they value. And with that, they'll be able to go out and tell people about the services rendered, and it will help to prevent them from patronizing uncertified health practitioners. The objectives of our study, the aim of our study was to evaluate service quality and improve service quality in Bayelsa State. And then we had objectives to compare the perceptions and the expectations and the perceptions of service quality in the health worker population and in the patient population, and to know the gaps that will meet. Next slide. Okay, thanks. Okay, so our methodology. We did a convenience cross-sectional survey or sampling, in 12 primary and 8 secondary facilities in Bayelsa State, and 67, sorry, are you moving? Sorry, I'll just continue. So our methodology was a convenience cross-sectional study. Convenience cross-sectional study across 12 primary health centers and 8 secondary health centers in the 8 local government Bayelsa State. 67 health workers were interviewed, 200 patients were interviewed as well. We used the self-qual questionnaire to investigate workers' and patients' perception and expectations, and the data was analyzed using the Microsoft 2013 software. The self-qual questionnaire is a questionnaire that was developed in 1985 and has been used in several sectors to evaluate health quality. There are other that have been used, but we chose the self-qual questionnaire in our study. The self-qual questionnaire had, please go to the next slide. No. The next, and then the next again, please. Okay, the self-qual questionnaire has 5 dimensions: tangibles, reliability, responsiveness, empathy, and assurance. Now, these were the dimensions we evaluated in patients in the health worker, in the respondents of the health worker group and the patient group. Next, please. Okay, the respondents profile, we had more males, more male respondents in the health worker group and more female respondents in the patient group. We also had more doctors that responded compared to other health workers. And then the distribution of respondents, we had more in Yanagua, local governments, and then was next, probably because of proximity. Also noticed from our results that the expectations in patients that are in tertiary and postgraduate educational qualification were more than their primary and secondary counterparts. And then people expected better quality from those in secondary health facilities compared to primary health facilities. Please, next slide. Okay, so the summary of health workers' expectation, perception, and gap scores using the self-qual model was that you can see the blue bars there represent the patient's expectations. The orange bars represent the health workers' expectations. The orange bar represents their perception. So there's a gap there, which is in the negative, the gray bar. So if you see it across all the dimensions, tangible, responsiveness, reliability, and empathy, there is a gap in every dimension evaluated in the study from the health workers group. And then from the patient group, we also had gaps, but surprisingly, we had a positive gap score in the empathy dimension of empathy dimension. So the net average gap score for 5 dimensions was 0.93 and minus 1.23 respectively in the patient and health worker group. And then, no, please, next. Okay, empathy was the only dimension in patient population with the positive gap. We had significant differences between the perception and expectation with a p-value of less than 0.05. And there was a difference between expectations in educational qualification and the type of health facilities. Please, our next slide. Okay, so conclusion, the dimension of service quality were mostly negative. The health sector needs improvements in these dimensions to close the gap. Health workers recommended improvement in infrastructure, in equipment and manpower development. Thank you.
Thank you very much, Dr. Alade, for a wonderful presentation. Please, let's take note of our questions. By the end of the whole presentations, we are going to take all of them. Just write down your questions, our comments. Let's make welcome of our Honorable Commissioner for Health, Dr. Newton Pabara Iguele, who is making this very event very possible. Let's give him a round of applause. Let's welcome him. You are welcome, sir. Also make welcome of the Chairman, House Committee on Health, Bayelsa State House of Assembly, Dr. Oyinke. God bless. Let's welcome him with a round of applause. I'll give to my co-chair to announce the next presentation.
We'll be going on to our third presentation, and that presentation will be taken by Dr. Bamidele Odusote. And the presentation is Improving Reproductive Health Outcomes Through Tax Shifting in Bayelsa State. Dr. Bamidele, you are welcome.
Good
Your
morning.
time is 8 minutes and it starts now.
Good morning. So this presentation will focus on highlighting the effects of domesticating the task shifting task sharing policy on reproductive health outcomes in Bayelsa State. Next slide, please. It became important to domesticate the task shifting task sharing policy in Bayelsa State because at the moment, Bayelsa State currently falls short of national targets on MCPR coverage. Bayelsa State currently ranks 3.3% in its MCPR coverage. This is modern contraceptive prevalence rate. And unmet need for family planning currently stands at about 29.9% in the state. This gory situation was contributed to or facilitated by the low levels of human resource for health, constraining availability of family planning services, particularly at the grassroots level. In plain English, there were not enough service providers in the state to provide contraception to women who needed them mostly, especially at the community level. And when you look at the data suggests that at the community level, the access points for a number of services are community health workers. So it became important to domesticate the task shifting, task sharing policy in order to expand the portfolio of health workers available at the community level who can provide services to women at this level. Next slide, please. In domesticating the task shifting, task sharing policy in Bayelsa State, we adopted a systematic approach. We began first with a situational analysis. In plain English, this means collecting data in the state to understand the state's health ecosystem so that we can domesticate a policy that takes into consideration local context. We collected data through a number of methods. One was desk reviews, and we did key informant interviews. We also did stakeholder analysis. Following the situational analysis, it was important to secure state buy-in. To secure state buy-in, we prioritized advocacy engagement across multiple levels. Upon conclusion of the advocacy engagement, we then formed a steering committee chaired by the Honorable Commissioner. Following the securing state buy-in, we went ahead to build consensus amongst the key stakeholders. What this involved was meeting with the stakeholders to agree on components of the national task shifting, task sharing policy that would be adapted, the ones that would be directly adopted, and additions and tweaks that needed to be made so that the policy will be very effective in the local context. At the end of the consensus building, we then went ahead to begin implementation. Again, under the oversight of the steering committee led by the Honorable Commissioner, we developed an implementation framework, an implementation plan, and we began rolling it out, mobilizing funds as we went along in the process. Next slide, please. Throughout the process of domesticating the task shifting, task sharing policy in Bayelsa State, we were able to achieve a number of results, even prior to implementing the policy in the state. The first result that we achieved was we saw a drastic increase in awareness on reproductive health policy as a basis for achieving outcomes within the reproductive health ecosystem in Bayelsa State. The next one, which was almost a direct consequence of domesticating a policy like that creates enabling environment, was we saw an almost double improvement or increase in the number of service providers that were trained for family planning. The percentage shot up to about 110%. This is what happens when you create enabling environments for a program. You begin to see all manner of influx of training to allow the program to actually take place. Other direct achievements were increase in funding and facilitators to support implementation of RH programs, specifically family planning programs in the state.
I must flag, though, that throughout the implementation process, we made sure to prioritize a multi-stakeholder approach in domesticating the policy in the state. Multi-stakeholder meaning that we engage not just key actors in the health ecosystem, but also stakeholders that are cross-cutting, ranging from women affairs to budget and planning to finance, to ensure that the policy that we were domesticating was robust and could easily take off at the point of implementation. Next slide, please. Just highlighting some of the achievements that I said in the previous slide. What we did realize was upon domestication of the CSTS policy in Bayelsa State, there was sort of an upward spiral in the number of service providers that were trained and skilled to provide family planning services within the state. The training started in about February and have run since then. We have a few slated for this year, but you can see that there's an upward projection, the number of service providers that are trained and available to provide family planning services in the state. Next slide, please. Again, once you train providers and they are willing and they go out, the resources are there, what you then see is an uptake in family planning services. So I'm sure it comes as no surprise to most of us that once we created the enabling environment and the trainings followed, the next thing we saw was an upshoot in uptake of services. Again, a drastic spiral from Q1 in 2020 up to Q2 in 2021. We've seen increased uptake of family planning services across the state, just because we prioritized building the capacity of community health workers so that women at the grassroots level who need these services are able to access them when they need them. Next slide, please. I have stressed throughout the presentation that enabling environment is the basis for one, attracting partners to the state to support a number of initiatives, especially ones that involve capacity building. Once the enabling environment exists, we expect partners to leverage on the ecosystem that has been created, come in and support training. This is just to emphasize that trainings and prioritization of domestication of policies is really the basis to achieve any sustained result, particularly within the reproductive health ecosystem in Bayelsa State. Thank you. I have come to the end of my talk.
Thank you very much, Bamidele Odusote, for a very articulate presentation. I wish to apologize to this house on behalf of the organizers about the screen that is not very visible. Our apologies, please. And I also wish to inform us that in the book of abstracts, you have all the presentations within. You can actually open it and follow up as they present. Thank you very much. Please accept our apologies. On this note, we're going to call on the fourth presentation, going to be taken by Oya Joju Tolulokwe, medical manager, Friesland Campina. You are welcome, sir. You are welcome to the stage. Let's welcome him with a round of applause.
Okay, thank you very much, sir. The Honorable Commissioner for Health, Bayelsa State, distinguished stakeholders in the health sector of Bayelsa, all other protocols duly observed. I'll be talking to us this morning about the role of DHA in visual and brain development. And the outline for my presentation, I'll be talking about myself, my company, visual and brain development, DHA and its role in visual and brain development, expert recommendation, and then what my offering is. The company is Royal Friesland Campina. We are a multinational dairy company with our head office in the Netherlands. We are owned by over 19,000 farmers. We have a long history. We've been in Nigeria since 1954. In 2004, we celebrated our 50th anniversary in Nigeria. We are the makers of pig milk and 3 crans. And we are guided by an inspiring mission to nourish Nigerians with quality dairy nutrition from cradle to adulthood. we are strongly driven by innovation and research. And we have a corporate commitment to empower healthcare practitioners with scientific and factual information about child and nutrition and health generally. So going fully into my presentation, I'll be talking about the role of DHA in brain development. Keep going, keep moving, keep moving. Okay. Keep moving. All right, thank you very much. So I'll be talking about the role of DHA in visual and brain development. I'll be looking at the eye and the brain. Okay, I'll be looking at the eye and the brain. One of the most important senses for learning and memory is actually vision. And in fact, vision takes up to about half of the brain resources. So we can see the interconnectivity between the brain and the eye. And then we'll be looking at the role that DHA plays in all of this. So 97% of omega-3 fatty acid in the brain is actually DHA. And also in the eye, 93% of omega-3 fatty acid in the eye is also DHA. So if DHA is this important, what does DHA actually do? So looking at one of the studies that was carried out from a randomized clinical trial, it shows that in a 12-month-old, that DHA supplemented, in fact, actually experienced a 1.5 line difference on the standard eye chart when compared to those that didn't get food supplemented with DHA. Also, we saw that DHA contributes to the visual recognition memory of the child. It helps in problem-solving ability and also in reasoning and cognitive speediness. All of these claims are actually not about ourselves alone, but these are scientific research that have been validated by a number of bodies, global bodies worldwide. So I'll be talking about giving examples of one or two of such bodies. The first one is the first one is the World Association of Perinatal Medicine. They said newborns should receive low-chain polyunsaturated fatty acid. An example of enough efficient to support optimal visual and cognitive development. Also, to support this, the Food and Agricultural Organization of the United Nations also says that DHA has favorable effect on rod photoreceptor, visual acuity, and neural function in infants. So, it cannot be gainsaying that breast milk is actually the best for babies, and DHA is actually very much found in breast milk. However, there are situations where the breast milk might not be available, and WHO recommends that when breast milk is not available, a suitable breast milk substitute that can offer what breast milk actually offers is meant to be given. So in line with our own mission in Freestone Campina Wamco Nigeria PLC, to nourish Nigerians with quality dairy nutrition, I present to you our own unique product offering for babies between 0 to 12 months. Big Baby has actually been fortified with DHA, which helps with brain development. As I round up and I close, Big Baby also has all other nutrients that helps to support consistently the growth, the optimal growth and development of the child in the first year of life. Distinguished stakeholders in the Bayelsa state, I believe that we have been empowered with the right information this morning about the options available to us when breast milk is not available for babies between the age of 0 to 12 months. Thank you very much.
Thank you very much to Lutokwe for a well-done presentation. Right now, we are going to take questions from all the presenters. But before we do that, I will give to my co-chair, Let her introduce somebody very important.
Good morning once again. While the presentations were going on, one of our leading medical directors stepped in. That's no other person than my own brother and my boss, Dr. Dennis Alagwa, the MD of Federal Medical Center, Yenegua. Let's give it up for him. Sir, you are welcome. So we have taken 4 presentations. The first presentation was taken by Dr. Aworabi, and we have taken her questions and her comments. Now we'll be going on to the other 3 presentations. The second presentation on evaluation of service quality in primary and secondary health facility in Bayelsa, taken by Dr. Alade, and the third presentation, take the effect of tax shifting and tax sharing on reproductive health outcomes in Bayelsa State, taken by Bamidele from Corona Management Systems. And we have our 4th presentation that was on the role of DHA on visual and brain development, taken by Oya Joje Tolulope from Friesland Campaigner. So the floor is now open to comments, questions. But before I open the floor, I would use the privilege of being the co-chair to start with my own comments. I'll be making a comment on the second presentation, evaluation of service quality. Now, listening to the presentation, I want to say what we know about quality of care, it's divided into 3, the structure, the process, and the outcome. Now, listening to the presentation, I think I heard more of our process, and we didn't really look very much into our outcomes. I don't know if that was on purpose, if that's how it was designed, because if we're looking at our structure, we'll be looking at accessibility when you look at location, distance, cost, acceptability of your services. So I want to maybe make a comment or ask a question. Was that on purpose to leave that out? Or was it put into the study and maybe something else? Thank you very much.
Let the presenters take note of their questions, and they will all respond when we are done with questions. So let's get piece of papers, write your questions. You can also signify by raising up your hands, so the mic will be given to you and you ask your questions. Let's do that. Let's take 3 questions each for the presenters. Okay, you have a question?
Yes. Let me start with the last presenter's question. You talked about peak milk, very good for your eyes and
Yes, which one, sir? Is it Ilera or conventional IECD? Okay. Yeah, yes, we do, sir. We do. Yes, sir. It's 10,000 naira, sir. Yes, 50 pieces. Good morning, sir. Good morning, sir. Very fine, sir. Yes, sir. Yes, sir. It's 50 pieces that is inside. It comes by 50, sir. So each one is actually 200. Yes, yes.
have training and retraining for community health practitioners quarterly in order to improve reproductive health at the primary sector? Thank you.
Okay, we are going to take the very last question. This elder here.
Thank you very much for your presentations. I have just two questions. The first is to the presenter for reproductive health. Just as an addition to what he said, when you were presenting, you kept saying in clear terms, in simple terms. I was waiting to hear in simple terms what exactly tax sharing and tax shifting is, and who exactly is supposed to be doing this, especially at the community level. Then for the last presenter, I have a problem with some of those products, because most times you look at it, they are tailored to either the middle class or to the upper class. What exactly are we doing for the bulk of the community that is out there, where the grunt of malnutrition is so severe and so far-reaching? Do we have product options that are packaged in ways, in smaller packages that are affordable to them, so that those needs, if you say that these products, are actually targeted at some people for a particular reason, can they also benefit from that? Then secondly, when you say when breast milk is not available, what conditions? It's also good that we know what exactly it is when you say breast milk is not available. Thank you.
Thank you for your questions. Let's take the very last question and you respond. Please, presenters, your response should be straight to the point.
Good morning, everyone. I'm Dr. Boubacar Dieng from Gavi. I'm a consultant to Gavi. Just, I want to step in what the Vice Chair was talking about the evaluation for the topic. I would advise you maybe when you are talking about input, process, and outcome, maybe to use the Tanahashi model to allow you to qualify evaluating health services. Because of what? Everything is linked to standard policy and SOPs. If you did not insert that one here, you will be missing the point. Are you getting me? This is my small advice. The number two, for all the presenters, I think you have presented something which is a casting tone. I don't know why and how. I did not see any limitation in your presentation. Your presentation doesn't have a limitation, which means you have presented something which is unbeatable. Thank you.
Thank you very much, sir, for your inputs. Maybe because of time, they couldn't actually tell us about their limitations. Let's respond to the questions. And Dr. Alade, start with your own response. Well, before you start responding, let me introduce to the House one very important personality that walked in as we were doing our presentation, Dr. Ayakeme Tonkiri, the Special Advisor Health to the Governor of Bayelsa State. Please, you are welcome, sir. Let's welcome you with a round of applause. Dr. Alade, you can come and respond to your questions, and immediately followed by Bamidele.
Much for the questions. I'll go with the first question. Said quality of hair is observed through structure, processes, and outcome. Now, I mentioned that I used a particular model. There are different models because of the intangibility of measuring quality. Different quality means different things to different people. So you can't, straight jacket say this is what service quality is, except you use a particular model. Now, different models have been used over time in different sectors, banking sector, supermarkets, and all that. And these models try to include this processes, structure, and outcome in them. Now, the model I used was SEFQUA model. It has 5 dimensions: tangibility, assurance, reliability, responsiveness, and empathy. Now, the tangibility would include accessibility, availability. Those questions were asked in the questionnaire. Because of time, we couldn't break it down, to each of the questions that were asked, so we had to breeze through. So those were included as part of tangibles and responsiveness. Then for the processes, That's the delivery of care by the health workers. How do patients see the care we render to them? And that was also included in empathy. As I said, we had a positive gap in empathy, surprisingly, because I actually felt that we would see all negative gaps in all the dimensions measured, but probably because, you know, the primary health facilities and secondary health facilities, those that work there are close to them in the community, and then they have one-on-one interactions. So it's a possibility that the people that responded saw it as, you know, having exceeded their expectations. So that was all included in the model I used. There are other models that measure service quality. Now, the next question was the 8 local governments. Yes, we're able to touch. It was a convenient sampling. It's maybe limitations, as you mentioned, you know, we couldn't go, it's my own study. I actually wanted to see what service quality, you know, how we, because sometimes you'll be, and they'll call you, doctor.
At subnational level, including in Bayelsa State. And we are working with the states to ensure that the trainings that we have started to roll out since first quarter of 2020 continue to allow more health workers to be trained, more lower cadre health workers to be trained on provision of family planning services. I hope that addresses it.
Thank you very much. The man from Friesland, Campina, can you please respond to your questions?
All right, thank you very much, sir. I have 2 questions. The first one from you, sir. Thank you very much for the feedback. It is well noted. However, I don't think there's any point we ever communicated to people to use hot water when they are preparing the general pig milk. But I'll take it back to market also that you may not want to prepare your milk with hot water. So for the one I presented is actually the baby milk. And we know that mothers are experienced in that regard to test the water they want to use to prepare the baby milk to be sure that it is actually lukewarm. Okay, for the second question, what are we doing for the low socioeconomic class? We have a mission that we are sticking to. For every product that we have that is on the high end, we have what we position for the lower socioeconomic class. For Pig Baby infant formula, what we have is My Boy Health Ring. For Friso Goat cereal, what we have is the newly introduced Pig infant cereal. So we have everybody in mind when we design our products. Thank you very much, ma'am.
Thank you very much. This brings us to the end of this session. I want to appreciate everyone for being part of this session. I appreciate my co-chair and those that worked with me in making this session a success. Thank you and God bless you. And now we are going to have a pictures session with the commissioner. You see, the poster presentation is going to take place during the break. There's a little change in schedule or plans. Poster presentation will be taken during the break. Next is plenary sessions. But before then, picture with the Commissioner of Health and other dignitaries. Thank you. And also, I want to announce that our oral presentation continues tomorrow, 9 a.m. Thank you, and God bless.
Thank you very much. I'd like to personally appreciate the chair and the co-chair, and of course the different presenters for the wonderful presentations they have given to us this morning. And I think they deserve a much, much better round of applause. Just like you heard from the chair, the initial plan was for us to go for the posters, but because of time, which is the plenary. And the topic for the plenary is strategic partnerships for health. Like you very well, the plenary will have to be doing with a panel discussion. And it is my pleasure at this point to introduce to us the chairman Okay, just before we move on to the plenary, the presenters are requested to step forward for a group photograph with the Honorable Commissioner. I think the chairman of the House Committee on Health should also be part of the group photograph, and possibly the special advisor to the Governor on Health too should please join them. Thank you very much. Thank you. With the group photographs done, we'll now be moving on to plenary 2. And like I earlier said, the topic for our panel discussion this morning is strategic partnerships. And the chairman of plenary this morning is Dr. Chijioke Kaduru. Let's please put hands together for him. Let me just give us a brief resume about Dr. Chijioke Kaduru. Dr. Chijioke Kaduru is a public health physician working for over a decade in public health program management. He has worked over the years in improving child survival and work towards gender equality through policy research, supporting polio eradication and routine immunization programs, strengthening family planning programs, implementing communications for development interventions, and implementing women's economic empowerment interventions. He is currently the Health Division Lead for Corona Management Systems and provide technical assistance to the Bayelsa State Government. Shall we please once again put hands together for Dr. Chijioke Kaduru. At this point, I'll be yielding the microphone to him.
Dr. Banai is also a public health physician and an infectious disease epidemiologist in training. She has previously led the school health desk for Bayelsa State and has worked over the past few years in a multi-partner coordination mechanism for routine immunization in Bayelsa State. So please also warmly welcome Dr. Banai. So our session will also be supported by a team of rapporteurs who will be helping make sure that we have a standardized and well-documented session across board. This session will be focusing on partnership, as we all recognize that government alone would not be able to deliver all of the health services that our people require towards improving their health outcomes. And so it is important for government to explore all manners of partnerships in a bid to ultimately transform or reform our health systems to deliver the kind of health systems outcomes that our people deserve. To be able to set us off on this panel, we have a distinguished list of speakers who will be sharing with us their experiences, their thoughts, and helping us articulate a way forward around partnerships for the health system in Bayelsa State. So we'll be starting with none other than our Honorable Commissioner for Health. He's a medical doctor. He is our host, our convener for this health summit. He's dynamic, he's strong-willed, and he continues to demonstrate a clear vision for the health system in Bayelsa State. Please warmly welcome Dr. Barbara Newton Igwele. The World Health Organization have also consistently supported countries around the world and provided strategic leadership for health across many countries, and especially here in Nigeria. We'll also be inviting a public health physician from the World Health Organization who's here on behalf of the country representative, and would like to warmly welcome Dr. Kofi Boateng from the World Health Organization team. Please a round of applause for Dr. Kofi. So whilst we're waiting for Dr. Kofi to join us on stage, would also like to very quickly invite colleagues from the Federal Ministry of Health. We have here with us Dr. Omobolanle Olowu, MNI. She's an ophthalmologist. She's led the National Program for the Prevention of Blindness. She's an alumni of the National Institute of Policy and Strategic Studies in Kuru. She's also the Director of Special Projects in the Federal Ministry of Health and leads the private-public partnership and diaspora unit of the Federal Ministry of Health. A round of applause for her, please.
Welcome, ma. Okay. The fourth person on our panel is Dr. Hadiza Kamfo. Dr. Hadiza is currently the Acting Country Director of FHI 360 Nigeria, overseeing projects in Nigeria country portfolio in health, education, nutrition, gender and gender-based violence response, private sector engagement and humanitarian and crisis response. She doubles as the Deputy Chief of Party for CEDAS, overseeing the functions of three technical departments: prevention, care and treatment, monitoring and evaluation, and health treatment strengthening and laboratory services. You're welcome, ma'am. The next person to join us on the panel is Munia Elelu. He's a pharmacy graduate of the prestigious Ahmadu Bello University, Zaria, and holds a Master's of Public Health degree from the University of Ilorin. He's currently the Program Director of the Pharmaceutical Society of Nigeria Foundation and the NGO and project arm of the Pharmaceutical Society of Nigeria. He's a retired Director of Pharmaceutical Services of the Federal Capital Territory. He's also the current National Deputy Chairman North of the PSN. You're welcome, sir. And lastly on the panel is Obinna Ukachukwu. Obinna Ukachukwu is an impact-driven business growth expert with almost 2 decades of experience across the banking and healthcare finance and development finance. He has served in various senior roles in his career, thus giving him valuable boardroom experience. He's currently the divisional head at Sterling Bank, covering the health and education sectors. In this role, he seeks to create solutions that enables access and the distribution of services across both sectors. Welcome, sir.
Please, a warm round of applause for all of our panelists, please. So for all of us who are here today, what we're hopefully going to explore during the session is looking at the opportunities for partnership between the state government and the national government, between the state government and development partners and implementing partners, as well as between the state government and other non-state actors, and then with the private sector as well. It would give us an opportunity to have an expansive conversation around all of the different types of partnership that can happen and how those partnerships can potentially help us in our efforts to strengthen the health system, not just in Bayelsa State, but across the country and around the world. So thank you very much, our wonderful panelists, for joining us on this session. We would start with an initial round of questions for all of you that allows you about 2 to 3 minutes to share some of your thoughts and experiences around the work that you do and around partnerships. We'll then also go ahead with some targeted questions. We'll also be encouraging our audiences at home and online who are joining us to share their questions and comments, as well as some of our audiences here who will encourage to write down their questions that will be handed over to our second co-chair and will hopefully respond to them. And ultimately, we'll try to wrap up the session with a few finishing comments. So of course, it's important to start our conversation with some state context. So I'll start by turning to our Honorable Commissioner to just find out from you, sir, based on all of your own vision and work and leadership of the health system in Bayelsa State, we would really like you to share some of your initial thoughts of how you think or what partnership means for you and where you think Bayelsa State sits in that entire spectrum of partnerships.
I want to say a very big thank you to Dr. Kadu and Nene and our viewers all over the world. Bayelsa State, we are prepared and ready to partner with any organization to ensure that we improve the healthcare indices of our people. First and foremost, whatever we are doing here, I am a very frank person and plain person. We were sent to school so as we'll have food on our table. That's the basic thing we are all here about. Even as we're trying to improve the health needs of our people, the baseline and bottom line issue is that we have to put food on our table. Dr. Obina, you can bear me witness. You're here in Bayelsa so that your company can pay you for the service you're rendering, isn't it? And so over the years, they have been scared. When Bayelsa name is dropped anywhere, everybody is scared. I can't come to Bayelsa. I can't reach Bayelsa because they are all militants. Dr. Lagwa, MD sir, that's what we used to get when we get to Abuja. But His Excellency, the Executive Governor of Bayelsa State, has improved on security outfits in Bayelsa State here. Over the years, about 2016 or thereabout, the statistics for crime in Nigeria, Bayelsa was ranked second. But currently, our statistics has improved drastically. I think about 2 months ago, His Excellency, the Executive Governor of Bayelsa State, called for a state security. Boat ride, and one of the directors just told me that he shouldn't go back to. So the first thing is security. His Excellency has ensured that Bayelsa is as safe as possible. And you can bear me witness. Sometime last year around October, the whole country was shaking with the NSAS protest. And believe you me, there was violence across the whole federation. But to suffice it to note that Bayelsa State never recorded any case of any violence. The people here in Bayelsa protested peacefully because of the leadership of His Excellency Senator Doedri, who has placed a good leadership in it, and we must give credence to him for that. So let's give him a hand of applause. And so by the special grace of God, you're safe. Whatever partners, wherever you're coming from, you're safe to come and do business here in Bayelsa State, to partner with us and ensure that whatever you do, your life is being protected, that you go back to your family, to join your family, whatever you're doing. And then secondly, you see, I say this everywhere, and I'll keep saying it. No government alone can support or fund healthcare indices. And I often say this also. What happened in the healthcare industry, about 95% of what happened are things we do not appreciate. You have the malaria eradication program, HIV program. There are a lot of programs in the healthcare industry. And it is very difficult for people to measure those programs, especially with the electorate. I put it to you, Obina, if you're even a governor, it will be very difficult for you to invest on programs that people, your electorate, will not vote you, because if you say I invested 1 billion on malaria eradication program, people will not see it now, not be so. People will not see it. And so it's very difficult. It will take a governor who has the will and the pains, who feel the pains of the people, to invest on that. And so by the special grace of God, His Excellency knew this and said, no, Bayelsas, we need to sit down and restructure our system to ensure that those things that people do not appreciate and hold tangibly, we should invest on it. We should let the populace know that this 95% of what happened in the health sector are things we should measure also, are things we should vote our leaders also. And so that is why we are holding this health summit. That's the essence of this health summit. So for a governor to say, let's hold a health summit, then it's obvious that he's ready for partners to come and invest in those areas that people who really do not appreciate. And so by the special grace of God, the Bayelsa State government, through this summit and after the summit, is being put in the right path in the things of government to ensure that whatsoever you want to come and do in Bayelsa will be appreciated by the people. Thank you very much, and God bless you.
So, thank you very much, Orim Commissioner, for that bit of state context, both in the context of the security apparatuses and improvements in security, and also in just laying out your thoughts and how you envision that partnership emerging. I think then it will be important to also get some context from someone who's been supporting the state over a long period of time. So Dr. Hadiza, your team has been supporting Bayelsa for nearly a decade. So we just also want to hear from you, what are your experiences of partnering with Bayelsa State?
So good afternoon, or is it morning? Yes, Joe. It's really a delight to be in this conversation, and I'm just going to take a cue. I'm going to take a cue from the Honorable Commissioner. He mentioned some very, very important things, that politicians will rather invest in things that are tangible, things that you can see. Okay? Unfortunately, that stance, does not help when it comes to the donor community. The donor community would like to see that you are in the driver's seat and you are making significant investment in your own society, to your own people, before they can commit to making significant investment in your own state. So what you will find is that a lot of times, when the donor sees that the enabling environment is right in a state, then they are encouraged to come in. So I want you to make sure that you communicate that with our politicians, and they must understand that, no matter what, you need to be smart and very strategic about the way you are able to attract, investment in your state, by first of all showing that there is strong ownership and there is a drive towards a comprehensive look to systems, and health system strengthening as a whole, so that whoever is coming will be building upon your own strategic plan. And that's why I'm happy about this summit. This summit is a clear demonstration of leadership and ownership, but we must get it right. We must get it right to say that, yes, we must always look at the entire strategic plan and map out resources in such a way that it is clear who is doing what, So if the government says we will prefer to invest in structures, let's see the structures that you are investing in. And let's also quantify the cost of these structures that you are investing in. If you say you are investing in human resource, that can be quantified. And then we'll begin to see other intangible things that donors and implementing partners are contributing to. So basically the emphasis here is on transparency and accountability. Once there's a transparent and an accountable system, it encourages everybody. I can bet you that just talking about this summit now, everybody will be like, wow, Bayelsa held a summit. Okay, what is the outcome of that summit? It cannot just be a talk show where we finish talk and there is no action afterwards. So there must be very clear and articulated plan, action plan and with clear milestones so that, within the next 1 year, we can say, as a result of this summit, this is how far we have gone. As a result of this summit, this is how much more we need to be able to move further. I can bet you that there are a lot of resources in this country. It is how effective and efficient we are with the management of the resource that is always a problem. So I can bet you that over the years, this state has benefited from World Bank investments. This state has benefited from DFID, the UN agencies, foundations, and private sector. This state has benefited from PEPFAR, from Global Fund, and a lot of others that I may not mention here. So the reality is that if you don't have a donor coordination platform that can see the big picture and see the big vision that you have for your state and know how each partner is keying into that vision, then there would always be these allegations to say that we don't know what these partners are doing or we don't know what this donor is doing, okay? But we can document these things and articulate them so that at any point in time, anybody can speak to it. So we must have a transparent and accountable system. So our strategic planning, I must emphasize, must be evidence-based, must emphasize use of data for decision-making, as well as performance management. Gone are the days when an IP can come and say, I have spent 100% of the money, but I achieve only 50% of the results. We must be looking at results. We must be looking at the money that is being spent and where it is going to. And we must also have a plan, a strategic plan that emphasizes transparency and accountability, like I have said. So having said that, at the planning stage or for any project is where the government needs to be brought to the table. At the planning stage, not when you are doing implementation. I can bet you that people in the public health department have participated in planning meetings and they know the work plan for their states. This is how much we have evolved over time. It's not like before where somebody can just sit up in his room and cook up things and just come and tell stories. It doesn't happen anymore. Donors are emphasizing transparency and accountability, and we must ride with that, okay? One of the fundamental components of any program, a vertical program that we implement, for example, maybe for response to HIV or response to TB or response to malaria, there must be elements of access and coverage. There must be integration into existing systems. If you do not integrate into existing systems, then we have missed the opportunity to build our own. But integration actually gives us that opportunity to be able to build our health system. So integration is an approach that must be adopted. And then lastly, there must be elements of ownership and sustainability. If we do not emphasize ownership and sustainability from the planning stage and make sure that the key elements from government are part and parcel of the planning and implementation, monitoring and evaluation, then we will never get it right. You can't come from anywhere and claim to know Bayelsa more than the people in Bayelsa, okay? And that is why I can proudly, I can proudly and happily look across the hall here and see people I have worked with for many, many years. Dr. Stowe is here, Dr. Ogoina is here. I mean, these are testaments to how much we have come, a long way in this state. In fact, I am so proud of this state because this state, when we approached them and said, in the past, during the emergency response to HIV, it was an emergency. So the fundamental approach was to basically go in and save lives as quickly as possible. But when we were designing the last project called CEDAS, which has lasted 10 years now, we are in the 10th year of CEDAS, we said the approach has to change. We have saved a lot of lives. Now we have to think about ownership and sustainability. You know what we did? We approached them and said, give us space. We want to embed ourselves within the Ministry of Health so that we are co-located with the government counterparts and we are working side by side with them. Over the years, about more than 500 volunteers, graduates of this state, have passed through the program. They go through a mentorship and coaching, program with us. And the ministry is keeping records of all these people. The good thing about it is that these are the same volunteers and interns that have now grown through the system and become big guys somewhere. They may not be working with FHI, but they may be working with the state has benefited as a result of that. So I can bet you that the approach, the integrated approach and the drive towards ownership and sustainability has helped to build a system in all areas. If you look at all the building blocks, you can see elements and facts that the system has been built, okay? Not just talking about service delivery, but also health workforce, health information systems, access to essential medicines. Now we have an integrated logistics system in the entire country as a result of the heavy investment in that. We also have health financing and leadership and governance that has been invested upon. So I just want to give one quick example before I round up. I know I've taken a lot of time, but the basic thing is that as a result of the investment, it has positioned us for the epidemics that have happened recently, starting with Ebola. FHI was funded by USAID to be able to establish some isolation centers across the country and also BSL 3 labs for MDR-TB. Initially, we thought the investment was for MDR-TB, but Ebola came. And very quickly, the Federal Ministry of Health assessed the system and said, where do we have facilities to be able to respond to Ebola? And these were the facilities that came in very, very handy. Then secondly, with the COVID-19 pandemic that has just come upon us recently, this is the same investments that we have used. The investments in HIV, TB, and malaria were used to be able to rise up to the occasion and respond to COVID-19. And in this state, the EOC was developed with funding from USAID. And of course, the ability to be able to diagnose COVID-19 was also set up within the PCR labs and the gene expert laboratories that were investment for TB and HIV. So vertical programs and investment in vertical disease control programs is a huge opportunity that we must not miss. We must take advantage of the opportunity and make sure that we own it and we drive the response. Thank you so much.
Thank you so much, Dr. Hadiza. So I like that. I like that across all of your comments and sharing your thoughts, you really harp on some very key issues. I hear you talk about leadership, about accountability and transparency, about resource efficiencies and effectiveness. I hear you talk about coordination. And somehow all of that conversation ultimately circles us back to the COVID-19 outbreak and all of our efforts in the preparedness and the response. And I think that now we're starting to head into recovery. And in the context of leadership, I probably want to pivot to Dr. Kofi and just find out, I mean, we're looking at recovery from the COVID-19 pandemic and going forward, not just health system strengthening, but also just advancing our health security agendas. So I would just like to know, what are your own thoughts on WHO's vision for sub-national partnership, just in the context of the post-COVID-19 world that we're moving into?
Thank you very much. Let me say, it's a privilege to be here. I'm stepping in for Dr. Kazadi, Honorable Commissioner. I think you are well informed about that. I think this is an opportune time for us to reflect deeply on the kind of partnership we have been having over the years. From the WHO, from the Ebola experience, there was a lot of lessons that came out from there, and following that, WHO has reoriented itself towards responding to these needs, specifically around improving access to universal health coverage, ensuring that we have health security, and also promoting the health and well-being of individuals. We have this banner headline saying triple billion. So by the end of our next 5 years, we want to make sure that we have 1 billion persons each benefiting from this. And we do this through policy dialogue, strategic support, technical assistance, and also service delivery in emergencies in particular. When it comes to Nigeria, you know that we have provided leadership and support to government to drive strategic plans. The current plan, as you know, we have developed a counterpart plan that responds to the needs of the country and what is coming out. And I'm very much interested in what's going to happen here in Bayelsa, where we have developed this strategic plan for the next 10 years. WHO would like to be guided by this global agenda and map up its functions towards supporting government to achieve these laudable objectives. In Bayelsa, we have been here over the years. I think our flagship program, the polio program, has been seen in all communities. And we want to use this opportunity to also commend government for the leadership in making sure that the polio eradication efforts in Nigeria really came to a success. Recently, through our support, a lot of technical supports to state to ensure that we are more responsive to this pandemic. And of course, we are also very much concerned about the disruptive tendencies of the pandemic, which has affected mostly essential health services. And I just don't want to belittle the point that my colleague here mentioned around the elements that should drive our thinking forward in terms of strategy. One of the key areas I would like to highlight is the area around accountability. And I think we need to open up the space for more transparency. For example, and I like to be very operational as much as possible. We need to map up our planning cycles and make sure the partners key in the planning cycle. We have challenges with verticalization that affect trying to understand outlook of resources that are needed for the state to meet its needs. And I think as partners during the coordination platform, that I'm sure will be strengthened from this summit, we need to ensure that as much as possible, the risk of verticalization does not affect strengthening the health system. And in terms of that, one critical area has to do with the integration of activities and skill sets. And we talk about integrated service delivery as if sometimes it is about just asking individuals to meet specific outputs. But the reality, though, is that it has a lot to do with the kind of health staff you are producing from the pipeline and how they will have to deliver the service in an integrated manner. Because all the spectrums of services that we are looking at draws down to the health facility or the community. So at each level, we need to be able to map out what functions are required for integration, try to build the capacity of individuals to provide that comprehensive service. And I think that will be one of the game changers if we can look at that. The other issue I want to raise, which the Honorable Commissioner has thoroughly addressed, which I think we need to look at, has to do with the insecurity and how it hampers continuous service delivery. From the polio experience in Bayelsa, we know the difficulties that we've had in case detection in most of the riverine areas. And because of such insecure environment, probably accounts for additional costs usually will not arise. And I'm so pleased to hear the Commissioner, the commitment government to make sure that we have discussion around modeling to ensure people actually reach out with these important services as much as possible. I also want to contribute around the areas of resource mobilization. it's obvious that as partners, we are all constricted by the financial mode.
Trying to put that into motion before he left the system. I was part of that team that started that process of the 6 geopolitical zones. In fact, a committee was set up
by the Commissioner of Health. And it is at this point that we can make input. Like we met with them when we were talking about the strategic planning. Our strategic plan 2 is almost coming to an end, and their own strategic plan 2 is also coming to an end. So this is the time, the appropriate time to sit down again and plan what Bayelsa State government wants. What the citizens of Bayelsa, their needs must also be factored into it. So this is essence of us, and that is the essence of the collaboration and partnership. Thank you very much.
Thank you. Thank you, Ma. Well, we know that many organizations other than health sectors are building on partnerships. Partnership is actually the way forward globally. So we believe that by the end of this summit, we'll actually know how we can access potential partners to come to Bayelsa, to support us, to build together with us and reform our systems. Thank you. So I'll
And I bet you Bayelsa State will no longer be the same after this. I pray. It's been a wonderful thing. And at the end of the day, I believe and hope that whatever strategies we put up will have an articulate plan, key performance indicators, along with timelines. Otherwise, it's going to be a waste. Presentations have been made. We've had a lot. This country is so talented when it comes to putting up intellectual presentations and what have you. But where we have the problem is implementation. And because most times those strategic action plans don't come with implementation plan, key performance indicators, as well as timelines. So I hope at the end of the day, this will have all that. 2, when this is coming up, I hope it's going to take into consideration all the components of the healthcare system. And it's going to bring in equity, fair play, preparedness on the part of all the actors, whether in public or private sector. Let me also mention that there is no health system that is worth its salt if it's devoid of pharmaceutical care or the pharmaceutical commodities. This is very key. Suggestions have been made, recommendations have been made since yesterday. However, for us, we have discovered that the private sector is an area for a long time whose potentials have not been fully tapped. Of course, donations and aids will not be forever. So we must be thinking of sustainability. And those are the key areas that the PSM Foundation as an organization looks into. We are an NGO arm of a professional association. And they will majorly focus on advocacy and policy development and review. We heard yesterday when the keynote address speaker said close to 60% of the Nigerian populace access healthcare through the private sector. And who are those in the private sector mostly? The community pharmacies and the patent and proprietary medicine vendors. Take it or leave it, we have a vacuum. You cannot find a community pharmacy in every local government area in this country, to the point of being satisfied in terms of serving the whole community adequately. So that vacuum is being filled by the patent and proprietary medicine vendors. However, how much of regulation do we have? How do we accredit them? How do we ensure that, yes, the practice within the review of the essential medicine list nationally. The 7th edition supported, which is a recent one, has just been launched. As of this morning, I just got a call again asking for support for the standard treatment guidelines. These are all components of the healthcare system that must come in. And for the first time now, we have an essential medicine list for children, which we also supported. We have also supported through the DRPC, which is our sub-grantor, HIV self-test, access to oral HIV self-test kits through the private sector. This ensures privacy, confidentiality, and all that. But one major thing I want to see is the community pharmacist is well placed. In every community, you find them, you find that the rate, or let me say the first port of call for most people are these pharmacies. And we advocate for a very strong inclusion of this group of healthcare givers. The PSN also has technical arms nationally. And the council also has the Pharmacist Council of Nigeria as a member, and so ensures regulation. So for us, we are prepared to collaborate with the state to ensure that the private sector is fully involved in turning the clock round. We are always prepared. We as a professional organization, we don't have the funding, but through projects that come through our own proposals and conceptualizing and whatever, to donor partners, we get funding. And from this, we do all it takes to ensure that the private sector is fully integrated and is fully part of this. The private sector, like the community pharmacy, you have a lot to gain from them. One, at any point in time, within any locality or community, where they are, be sure that being the first port of call for any health care seeking person, the basics will first be given or be done. 2, if they are properly trained, what I mean by that is capacity building. Apart from the professional you have had in school and whatever, they need to be retrained and build up capacity and ensure that we don't only have capacity building, but we have capacity empowerment. It does not suffice to just train somebody and leave him just on the bench that way. The enabling environment must be provided to allow for the community pharmacists to have the capacity empowerment. 2, referral system can be better off. You can link your community through the community pharmacy to referral system, and then be sure that data generated will be of utmost, will be very good. However, more participation of the private sector. That's it. We've all along been talking about the public sector, public sector, public sector. But when you look at it, the public sector does not have all it takes in terms of personnel, infrastructure, and all other things that have been mentioned since we've been here yesterday. We've had some states who have introduced rural pharmacy incentives to ensure that in communities where either the primary healthcare facility isn't working well or needs some upgrade or uplift or whatever, the community pharmacy there, when it's encouraged, can serve that purpose. In fact, in better climes, community pharmacies serve as primary healthcare centers. I wish you get there in this country very soon. And when you have their capacity building and empowerment, you can also be sure that things like data can be upmost. I also want to mention that the Pharmacists Council of Nigeria isn't resting on its house, and as a member of the council, we have what we call the hub and spoke, and also the satellite pharmacy incentive. And that is up once you have the pharmacy bill assented to by the president. And that will mean that in every locality, for you to be sure that service is optimum, or the kind of service that is being delivered, it's okay, there will be a center or a central pharmacy, community pharmacy, that will have a supervisory kind of role over all the other healthcare givers within that community. And as such, that can be a very good reference point. And once that is on, I think we'll be better for it. There is also the third accreditation system. Yes, we have the patent and proprietary medicine vendors all over. And let me tell you today, I think through the bill amelioration, and I think Integrate East Support and SFH, we have 2 states in this country that is already being used as pilots for this third accreditation system. For the PPMV, you have them from those who can read and write, right through to PhD holders. And certainly, you can't train them the same way, and you cannot be sure that all of them give a service. So we put them into tier, tier 1, tier 2, tier 3. And those, we segregate those who have health backgrounds, separate from those who don't. And we give them different scope of work and what to do. So I think with all this, we are prepared to support the state through the local chapter or even from the national, and ensure that the organized private sector part of this fully. Thank you.
Thank you, sir. Thank you so much. From all we've heard, we can see that there's clearly a role for everybody to play in terms of obtaining the kind of private healthcare system that we want. So that brings me to Obina Ukachukwu. You're also in the private sector. How do you, and where do we start the ball rolling with the private sector? Thank you.
Very much. Okay, so I'll try to go straight to the meat of your question. But before that, I'd say that, if one can do something alone, then there is no need for partnership. The reason you call for partnership is that you know that when you come together, you'll get better outcomes. In the States, you can get vaccines, you can get blood quickly, you can get things like oxytocin, and you keep cracking your brain. So how do I get this somewhere? There is technology that can make people do just-in-time services. They're all existing. Partnership means, how do you get all these people interested to cook this particular soup? And that's what we try to do. Knowing fully well that there are constraints. So the government might not be able to sink capital into building a drone service company in the state. So partnership means you bring your own drone service company, things like that. That's how we actually imagine it. You might want to solve for fake drugs. You want to solve for the cost of drugs, because today, when you look at the cost of drugs between a distributor and the end user, sometimes it's about 200%. It's about 300% margins that it's placed there. And the state is saying, oh, down. There is definitely a way to multinational players invest in this hub and spoke approach where people don't have to hold inventory. When you hold inventory in different places, it increases the cost because it's money you're using to hold it. But mainly you do things like just-in-time services, private sector players. Recently I was speaking to one of them, do your disease planning. How do you know what's happening? So usually very reactive. Why? Because someone is diagnosed with typhoid, it's entered into one paper in his file and it's stored in one desk somewhere, and you can find it. So the only way you can do this is to introduce technology. You have to go into electronic medical records. You have to have something like a digital registry where the state board can actually have real-time view of what is happening. And are these things far-fetched? No, they're not far-fetched. There are people that do it today. There are partners, there are private sector players that do it today, and you don't need to commit your capital into designing. Worst case scenario, in fact, it's going to be a transactional fee. So people are paying for their bills and they have to pay 10 naira extra just to provide for this technology service, and boom, it's solved. There is, if we decide to, if the public sector decides to do this particular thing I've talked about, you likely set up a board and you set up 3 committees. Before 4 years, the time is. There's no way you can solve for this without private sector. With private sector, call private sector in, work the modalities out, and in 6 months maximum, you're running and everything is visible. And people are wondering, how did you actually get this done? And it's just like that, it's on and on. If you think about health like food, health service is something people consume, meaning that beyond the health sector, collaboration and partnership will even boost the overall economy of the state. Is it technology? You're bringing in technology companies, you're thinking about bringing in drone services. You're going to grow you have homegrown engineers. Is it about digitizing drugs? You bring in, it's just far-reaching. The only challenge is that sometimes we try to do things in silos. The private sector is trying to solve something where they don't have policy backing for, they don't have an enabling environment for, while the public sector is trying to design things that already exist. In partnership, we try to pool our resources and our strengths together to make this thing work. And I call myself and my organization, I say, we're like the binder. We know everybody, we know the government, we know this, we know that. And we try to bring everybody into a room to say, let's solve for this. And when we have a willing government like the Bayelsa state government, I believe that this partnership can actually transform the health sector speedily, as in very fast, with real outcomes. We're not going to measure the outcomes on paper KPIs. We're going to see the outcomes in the lives of people. Thank you.
Thank you very much. I think that our panelists deserve a warm round of applause, please. I think that there's been a lot of insight from the different scopes of partnership that we have on display here in the context of the conversation. But our conversation can only be enriched by also reaching out to our audience and hearing some of the questions that they've penned down, either for the audience at home that have been using the chat box, or for the audiences that are here that have also shared their questions. So I'm going to just invite our co-chair, Dr. Banai, to share with us some of the questions that have come from the audience so far.
Thank you very much, Chair. Good afternoon, everyone. Thank you very much, panelists, too. Okay, I have a couple of questions here, 3 actually. I hope we can take all of them. The first one is actually start with a comment and then a question. Okay, so it says the state should continue to be drivers in terms of political will, commitment, and funding, including monitoring and evaluation of health interventions. It also says that states should display ownership at all times of programs. Now the question, what is the state doing to operationalize and implement the state's strategic health development plan, which has a component to include the private-public partnership? I think that's direct, that would be your purview, sir, Honorable Commissioner. And just there's a question to follow that's also for you, so I think I'll just take that at once. One of the things they kept talking about, the panelists kept talking about is accountability and transparency. So someone wants to know if this, how do I put it now? The political will to implement accountability. Because if somebody does something and knows that they will be held accountable for what they have done, it would deter the wrong thing. So is there any plan to ensure that there's accountability across board and across programs? So those are the 2 questions for Honorable Commissioner. And then the third one, sorry, for the, okay. I think this is for the pharmacists.
says, how will you draw a line between patent medicine vendors and community pharmacists in the remotest rural communities in effective quality healthcare deliveries? I don't know if you got that, sir. How would you draw a line between patent medicine vendors and community pharmacists in the remotest rural communities in effective quality healthcare deliveries? Thank you.
Thank you very much to our audiences, both here and online. So I think we'll just invite the comments from the Honorable Commissioner and also the comments from Pharmacist Munir. So Honorable Commissioner, sir.
Okay, thank you for that question. Okay, I want to for the question. The government that has set up this summit and is unrolling, is ongoing, is a government that is ready to be accountable, that is ready to own whatsoever Hello? Okay. I know my boss, the executive governor of Bayelsa State, Mr. Doediri. He has given us a free will as commissioners for us to operate in our various states and our ministries. And vis-a-vis, when we set up this planning committee, the SHA can attest to it, I never interfered with whatever they were doing. Whatever like this. And lastly, I want to assure us, every panelist, viewers across the world, that this is not going to be that Nigerian kind of pattern or effects over the years that will talk more and do little. My governor is very committed. Like I said, for someone to ensure that we put up such a meeting, a summit, they should know that he's very willing and ready. It's not very common in this country. He's very willing and very sure that whatever comes out of this summit as foregoing, he's ready to implement it hook, line, and sinker. And so be rest assured, we have told the committee whatever we're doing, we're giving a timeline. What are we going to achieve in the next 1 year? What are we going to achieve in the next 2 years? What are we going to achieve in the next 3 or 4 years? We have all of this in place, and we're going to have a check. We'll value, we'll monitor whatever we are doing after this summit. I hope that in the next 2 years or 1 year, we'll come back. We're able to see what we have done in the past 1 or 2 years by the special grace of God. And so I can assure everyone here that His Excellency will be very committed to whatever policy that will come out of this summit, and by the special grace of God, we'll implement them.
Thank you very much, Honorable Commissioner. We'll just also invite them from Assistant Munir.
Thank you for that question. It's good to clear the air so that there will be no ambiguity in recognizing a community pharmacy from that of a patent and proprietary medicine vendor. A community pharmacy is licensed to sell, dispense drugs and owned by a pharmacist who is trained as a PharmD graduate and is the superintendent or a pharmacist at any point in time when a patient comes in, I mean, a customer, client, whatever you call it, comes in for healthcare service. A pharmacist is licensed to export, import, manufacture, compound, mix drugs and medicaments. A patent medicine vendor is someone who can just barely read and write and has been licensed and is being regulated by the Pharmacist Council of Nigeria to only dispense over-the-counter medicines in the wholesome way it is from the manufacturer. And for pharmacies, there is an emblem for you to know that, well, this is a pharmacy, and you can be sure that if you go in there with the pharmacist, you can have the expertise in terms of your pharmaceutical care and counseling. For the patent medicine vendors, these are people who, right from decades ago, were brought in. I'm sorry to say it was an aberration, but then nature abhors vacuum. We are all here, but we have our parents, our families, and whatever, right inside the hinterland, where you don't even have, in some cases, any healthcare facility, not to talk of even a community pharmacy. So they are just in to just give the little necessary healthcare need of whoever seeks at that point in time. And we have a list of items that by law, a patent and proprietary medicine vendor can dispense. And we generally call them the OTC. Right now, what the PCN is trying to do is to ensure that we stratify them. You cannot do away with them. That's the fact. Like you have said in the hinterland. So what PCN is trying to do is to stratify them. If you can barely read and write, yes, you have just a simple short list of what you can do. For those who have health background, because right now we find so many people, once they retire any health practitioner, let me open a patent medicine and be selling medicine by the corner. So if you have health background, we put you into tier 2, where you're able to dispense and attend to patients a list of other OTC that are a little bit more advanced than the first set. And we have tier 3, which is mainly for the pharmacy technicians who have been trained in schools of health technology and are capable of handling within the scope of the regulation by the Pharmacist Council of Nigeria.
All right, so thank you very much, Pharmacist Munir, for just expanding on that a bit more for us and giving us some context as well as to how that can potentially key into our broader conversations around partnering and strengthening service delivery vis-a-vis how we regulate some of these different cadres of health workers that are out there for us as well. I think that we would really be losing out from all the wealth of experience that the panelists here have. And it's a joy that they're here with us for the next day and a half as well. And I will continue to be able to engage and interact and make sure that all of the different actors in the Bayelsa State Health System also get some time to interface and sort of tap into all of that experience as well. I think just some of the key things that are, consistently resonating across all of this conversation, the importance of state leadership and the state being the driver of those conversations around how we partner towards achieving better health outcomes for the citizens of the state. It continues to resonate that there's a hand-in-hand approach that needs to happen. So we shouldn't partner at very peripheral levels. It should go deep and start from planning and go all the way to the monitoring cycles. And we come back to the table to iterate and see new ways of doing things and strengthening them. It's good to see that there can be partnerships between government and government at a different level. All right, yes. I know I have dwelled a lot into the private sector, but from hindsight of my experience in the public sector, I just want to mention some areas that I think the state can also take a look into and see how to even improve the pharmaceutical services in the state. A rural posting incentive, I have said that, not only in the private sector, in the public sector. You can do that, and you can post your staff to the rural areas, give them rural posting allowance, and honestly speaking, you see them really work well there. Two, you can have what you call contract manufacturing with pharmaceutical companies. You don't need to go and pay from the onset. And ready market that the pharmaceutical companies are looking out for. Every quarter or per year or biannually, they bring in your drugs and whatever, and then you pay based on your discussion with them. You have to strengthen your DRF system with legislation. DRF has failed in so many areas because people have not been sanctioned and there are no legislation. So you need to look into that. I think a very good example is Kano and Jigawa now. They took all whatever, the whole DRF thing to the State House of Assembly, and it was legislated on. And it's working wonders there now. You might maybe call your colleague and in those states and find out. In FCT some time ago, when we discovered that the maternal had, we're looking for ways to improve antenatal care services. And the FCT introduced what we call the free antenatal care service. From the day the pregnant woman registers, it's free to the time she delivers and leaves the hospital. We did that and we did it successfully. It was so shocking that you have people
who come all the way from Port Harcourt when they are pregnant to come and deliver in Abuja. Somebody will leave Kano to come and deliver in Abuja, and all sorts. And it's jacked up even within the environs. Look at that. I know you already have a health insurance scheme. Look at the state essential medicine list. Do you have? If you don't have, ask, implementing, donor partners can assist in that to help you develop one and support that. And then you also look at, in fact, it should be a mandatory thing. Simple medicaments should be compounded within your hospitals. You don't need to be spending money doing that, buying methylated spirit, buying trisilicate, buying hand sanitizer. No. Empower them. They should be able to produce that within the hospital setting. So these are some of the areas I think I wanted to point. Thank you.
All right, thank you very much, Moses Munir. I think it would only be fair to also just give every other one of the panelists just 1 minute to share any last thoughts and recommendations as well from the state. We'll then take a final comment from the state as well, and then we'll be able to just wrap up the session. From Moses Munir, in particular, or I'll go to Dr. Hadiza. So just share your last thoughts, quick recommendations for the state, what you think that we can take away from here going forward. Start with you, Dr. Hadiza.
Okay, so we must ensure that we are able to derive the double benefit that comes from investment, from vertical programs, from donors and implementing partners, so that we can build
health system strengthening is very key. And I want to encourage you to engage other colleagues of yours, other commissioners, to key into this strategic plan. For us, WHO, be assured we are committed to the 3 billion and want to support your state in terms of addressing access to essential health services, especially at the primary healthcare level, to respond to health emergencies and securities, as well as also promote the variables around social determinants of health. I want to thank you once again for the opportunity.
Thank you very much, Dr. Kofi. Mr. Obina.
Thank you very much. I want to thank you for organizing this, and I want to tell you that we're committed to helping you get this off the ground. If it means by having to attach a project team from my office, I'll definitely do that to allow us to get off the ground. I want to also talk to our partners, our development partners, those who provide funds for us. I think we should look a lot more into supporting the what do you call it, the demand side. So there's a Bayelsa State Health Insurance Scheme. I believe strongly that if 80%, 90% of the funds that come into the state healthcare system comes in through the fund, it will find its way to doctor salaries, different projects inside. We've not really gotten the real benefit in people putting funds in select projects. It's just scattered. So if we can all go through the front, I think it will help the state organize itself and its resources a lot better. Thank you very much.
Thank you very much, Mr. Obina. So, Honorable Commissioner, any last words?
I want to thank you, panelists, and all viewers. stakeholders here present. You see, when we go out to meet at the federal level at various fora, they call us Bayelsans as orphan states because we do not have partners supporting us. And last, the basis of these summits is to ensure that we write our vision as the state, and the Holy Scripture says, write the vision, make it plain. He that reads will run with you. And I've often known that nobody can help us, nobody can save us as Bayelsans, except we Bayelsans. And that is what we are committed here to do by His Excellency, writing our vision, the plan of Bayelsa State in the area of health sector, to ensure that when you read, like Obinna has told me something off camera, my body, they sweet me because, Obinna, should I say it now? Okay, I should. Don't worry, you hear it very soon, what Obinna and his team is about to do for us as a state. And I hope that in the next 2 years, we'll be like King Solomon, who has several brides trying to come into Bayelsa to come and invest here in Bayelsa State. Once again, I want to say a very big thank you, and His Excellency is very committed to ensure that the Bayelsa State health indices improves significantly. Thank you very much, and God bless all of you.
So thank you very much to our audience for the time, for listening to us, for engaging with us, for sharing some of your thoughts and questions. We really have had wonderful engagements across board. We're also thankful to Mr. Obinna, Dr. Kofi, Pharmacist Munia, Dr. Hadiza, Dr. Lowu, and the Honorable Commissioner, as well as my co-chairs, Dr. Neni and Dr. Banai, for what has been an effective conversation around partnerships with some insights that we can take forward and hopefully grow the Bayelsa health system. So thank you everyone for your attention, and we'll move on to back to our MCs. Thank you.
Thank you very much, Dr. Kaduru. And the co-chair is, you take photographs downstairs, please. It's been a wonderful session. Please, we can give them a better round of applause. I know some of us are feeling a bit tired. Don't worry, we're going for tea break for just 20 minutes, please. And immediately after the tea break, no one will come and announce to you, or we might approach you, yes, so you can proceed for the parallel session. We're having the first parallel session. The first hall will be hall 2 upstairs, the big hall upstairs. Then the room 2 will be opposite it. There's another room there as room 2. Then the room 3, if you check your program, that's page 17 of the program. Take off the masks, please, just for the photographs, then you can mask up again. Then the room 3 is this main hall we're in. If you check the page 17, room 1, strengthening health security in Bayelsa State. That is the second hall, the big hall upstairs. Room 2 is opposite it, Bayelsa Emergency Medical Services and Ambulance System. And then room 3, which is this hall, for memorandums for consideration. And the first room, the chair is Biobele Abaye. And then room 2, we have Dr. Kesie Lemo. And room 3, we have Dr. Ebikapaye Okoyan. So these are our chairs for the parallel session. Please, for the tea break, we have one this way, we have another one upstairs, and we have one outside. So please, for the directors, the chief medical directors.
So tell me why about this
So please, we can proceed for tea break. You have just 20 minutes. Our advice, we start now. It's just 20 minutes, please.
I'm not afraid, I'm not afraid. If there's a cloud up above us, go on and let it rain. I'm sure I'm together.
And then if you're interested in seeing the posters, we're supposed to have poster presentation, but because of time, we couldn't. So you can still view those posters upstairs while you are having your tea break. Good enough, the snacks are in takeaway packs, so you can still be eating your snacks while you are looking at the posters.
I'm so crazy about love, never knowing what love's all about. James, will you come on in, man? You can blow now. Very far over land and sea.
Memorandum will be a presentation. This is the time we have before they finish this. So do whatever we need to do. That's what I'm doing. Huh? That's what I'm doing. I'm talking about this room.
Hello, hello. Distinguished gentlemen, good afternoon once again. I'd like to have your attention, please. Could the owner or driver to car number KMK 791AA, KMK 791AA, a Toyota Corolla car, please. Could the owner go and remove it from where it is presently parked? It is actually blocking a whole number of other cars. Once again, the driver or the owner of this Toyota Corolla with the number KMK 791AA, kindly please go and repack. Thank you. Without you, baby, don't have no fear. Oh, is there wonder why? I really feel in the mood. So tell me why stop to think about this weather. Slip dream I made where I go jump out of my head again. I touch together that would make me strong and brave. Oh, when we are one, I'm not afraid, I'm not afraid. If there's a cloud above us, go on and let it rain. I'm sure our love together will do. Oh, my baby. Let me get a release from this moment. What is all this talk about loving me? I'm not afraid. Not like before. Just let it be. Up on that. Every song. My heart's on. What you make me, my darling, my sweet, oh pretty baby, you make me feel so good. Let me take you by the hand. Come, let us visit out there in that new promised land. Maybe there we can find a good place to love and say goodbye. I'm so crazy about love. Never knowing what love's all about. James, will you come on in, man? You can blow now if you want to. Wonderful. This changing jacket boy. He wandered very far, very far. Over land and sea. It's a shine. Sad eye. Very wide. Wide fuzzy.
Christmas, ladies and gentlemen. Allow me to tell a story.
to know that I submitted this memorandum in clear understanding of the team objective, and then the opinions and suggestions proffered by me are strictly my perception about what I think is right. It is with some sense of knowledge and
please, somebody just pick up a phone in one of the conveniences upstairs. If you've gone there and misplaced your phone, please, you can come forward for identification and collection. Somebody left his or her phone in one of the toilets upstairs. So in case you have misplaced yours, simply come for identification and collection. I also would want to, at this point, crave the indulgence of our ushers or those charged with the responsibility of arranging the stage to quickly do so, so I can hand over to the chairman of the plenary, Dr. Zoboimi Agada, to take over. Please, let's do that very fast. It's been quite a tasking summit so far, but equally very, very rewarding. And like I said before, it is our hope and belief that healthcare delivery and indeed the development of facilities will never be the same after this summit in Bayelsa State. Please, let's quickly see how we can arrange the stage for the plenary. Okay, I've also just been told that we don't all need to come in here. You can remain in your different halls and you will still see whatever that is taking place here. If you wish to ask questions or make comments, you can still do so from your different halls. Please. Well, we're still waiting for the stage to be
percentage of GDP, gross domestic products. How do we expand our fiscal space? What are the sustainable domestic resource mobilization mechanisms we can apply in Bayelsa State to guarantee that the Bayelsa State government has more money to spend on health? On this note, ladies and gentlemen, may I crave your indulgence to invite my co-chair to introduce the presenter. Co-chair, please.
Thank you, my chair. Good afternoon, ladies and gentlemen. To do justice to this topic is an erudite scholar, an expert in healthcare financing in his own right. Dr. Obioma Obikeze is a consultant community physician and health insurance and managed care program coordinator at the Federal Medical Center, Yenagoa. He had his undergraduate training at the University of Nigeria, Enugu campus, where he graduated with the MBBS. Dr. Obikeze holds a Master of Science degree in International Health Policy and Management from Brandeis University, Massachusetts, USA, and another in Epidemiology and Medical Statistics from University of Ibadan. He also has various advanced certifications in healthcare, economics, financing, and insurance from several reputable international organizations and institutions, such as the World Bank, World Health Organization, Heidelberg University in Germany, and Johns Hopkins Bloomberg School of Public Health, Maryland, USA. He has offered health financing technical support to various government and private institutions, including the Federal Ministry of Health, National Institute for Policy and Strategic Studies, Development Research and Projects Center, the Bayelsa Health Insurance Scheme, and Afe Babalola University, among others, in pursuit of the vision of universal health coverage. He is a member of a number of professional associations that include International Health Economics Association, Nigeria Health Economics Association, Medical and Dental Consultants Association of Nigeria, Association of Public Health Physicians of Nigeria, Nigeria Medical Association, and Rotary. Obioma is married with 3 children. Ladies and gentlemen, please join me to welcome for his presentation, Dr. Obioma Obikeze.
Good afternoon, Mr. Chairman, and our guests. I'm happy to be before you today, and my task is simple: to disabuse our minds from some of the misconceptions we have always had as Nigerians, that there is so much money available. Some of our expectations from ministries of health and from governments have not been met, not only because of lack of commitment, but also because of some realities that we have to face. And that is why we want to look at today, why is it necessary to expand fiscal space for health? We also need to look at some economies that have been able to do it right. What lessons are we to learn from them? How can we apply the lessons to our own state, Bayelsa? By way of outline, I will look at introduction, where I will establish a business case for expanding fiscal space for health. I'll look at strategies that are supposed to be adopted to be able to do justice to that topic. Lessons from successful schemes, both from formal sector and informal sector programs, Then important next steps or recommendations. Then I will conclude. By way of definition, in his paper, The Prospects of Creating Fiscal Space for Health, for the health, Heller in 2006 defined fiscal space as the capacity of government to provide additional budgetary resources for a desired purpose without any prejudice to the sustainability of the financial position. Doing what the state has to do and yet not compromising accomplishing other tasks. He further explained that budgetary room, fiscal space, as that budgetary room that allows the government to provide resources for public purposes without impairing or impacting fiscal sustainability. That is, without threatening government solvency, given existing fiscal conditions and long-term requirements. Do they have to fund health only? Things that need to be done for government to be funding him Nigeria has. And McIntyre in 2012 is that many countries lack the data grants in 2019. How will you use it to plan for 2020? It becomes difficult. So these are some of the challenges we have. The authors also argued that such data form the prerequisite for what policies, measures, or decisions have been fiscal space for health. Efficiency improvements and efficiency gains from gains and economic growth. That was the conclusion of that research. Fiscal space being so important to us. Why? Why expand fiscal space for health? There are reasons, there are justifications. Clinical service delivery. Most of the presentations we have had here since this summit is about insufficiency of funds to fund the primary healthcare board, to fund services at the primary healthcare centers, to fund secondary services. And even those at the tertiary hospitals, they have also explained their reasons, their frustrations. So clinical service delivery is enough justification for us to expand the fiscal space for health. General social services. One of the presenters in the situation analysis was telling us about the gross underdevelopment of social determinants of health. If you don't have good water, cholera will always be there. If you don't have good water, people cannot drink enough. Other forms of gastroenteritis can come in. So if we have deficiencies or deficits in the social determinant of health, we need more money to take care of these things. And then human resource management and bureaucracy, funding health sector training institutions like Bayelsa Medical University, Niger Delta University Teaching Hospital, and Niger Delta University. These are the reasons why we need more money for health. Even funding bureaucracy of the Ministry of Health, sending people to Abuja for seminars and for workshops, you need money to do these things. And I will later tell you in this presentation why that money is not available. The key issue for Nigeria and for the developing countries is poverty. In 2015, Nigerian government general revenue as a proportion of gross domestic product was only about 5.9%. I want us to compare this to figures from Europe. We are looking at, of the total Nigeria's GDP in 2021, which is at 466 billion US dollars. Only about 5.9% of it is what Nigeria receives as total revenue from oil, from tax, from everywhere. Calculate it. There is no way it will fund our budget. Not to talk of giving substantial portion to health. This explains why you hear of borrowing from here, borrowing from there, because the money is not there compared to the need of government. Let us look at this chart. The average government general revenue in proportion to GDP ratio is 46.5% aggregate in Europe. Finland has 54.1%. More than half of the GDP is generated as revenue every year. That is robust. In France, it's 53.2. Germany, 45.1. Greece is 48.3. And Nigeria, 5.9. How do you compare the trend? Is a scandal. So you know where the state governments and federal government are coming from. In creating fiscal space for health, researchers have shown us specific options. Powell Jackson, Hansen, and McIntyre in 2012 told us that 5 key areas of approach will help any government that is serious to get something done. Looking at conducive macroeconomic environment, GDP growth and tax revenues, tax earmarks for health. I will later come to the issue of GSM tax, sin taxes, taxes from tobacco and alcohol, and also sugary foods. These are what other countries have been able to leverage on to raise more revenue for health. Efficiency improvements or gains, I have mentioned that before. External grants, depends on how it is applied. Either it depends on the way it is applied. Then prioritizing health within government budget. How far have we come close to 15% allocation agreed to by African governments in 2001? Going further, assessing the fiscal space for domestic funding of health and other social services, Bayelsa and McIntyre in 2017 examined the relationship between the expenditure on health and showed that a country's level of economic development does not necessarily predetermine its spending levels. Other factors actually predominate. The value that the government gives to health issues is a predominant factor. And that is where we call the honorable commissioners of health and ministers of health to put on their thinking cap and to understand that health is not an emotional thing. No government takes it serious until the individual is affected. They also caution that the purpose of raising government spending on health will be defeated if that spending were funded by increasing the relative tax burden of those who are going to benefit. You jack up VAT from 5% to 10%. You jack it up later to 15%. You are not necessarily helping the people who are benefiting from this. Rather, increase the tax net. There are other people that can pay this who have not been paying before. Research and examination will show government where to expand the tax net and help the system, not necessarily killing the people from one source. Earmarking means taking all or portion of total revenue from a tax or group of taxes and setting it aside or protecting it for a designated expenditure purpose. And today, more than 80 countries of the world are involved. Earmark of excise tax on tobacco and alcohol or sugary drinks to attain public health objectives in what BED in 2015 called taxing bad and doing good with the proceeds has been a source of succor for many countries. You tax those things that people that are causing social harm and individual harm and use the proceeds to fund public health. By implication, it will dissuade people from using or consuming that and plow that money into public health. It has been a measure more than 80 countries of the world are applying today to raise their fiscal space for health. Using results from research by its senior executive cost 41 participants, NIPS engaged with National Assembly between late 2019 and first quarter of 2020, and they were able to get telecom tax for earmark for health at the rate of 1 kobo per second of every outbound GSM call to be warehoused for health. And the good news about it is that the highest amount Nigeria has been able to set aside in the basic healthcare provision fund per year was in 2018 at the rate of 58 billion naira. But models created with GSM tax is to yield for Nigeria about 260 billion naira in 1 year. So without knowing that you are contributing to health, every Nigerian who is in GSM is contributing to health. And that earmark will do a lot of difference if we factor in corruption and transparency issues, or if we exclude them. Other earmark options for Nigeria also exist. Specific taxes on goods in some countries, you hear what we call consumption tax. For a toothpaste you buy at 200 naira, you pay 6.5%. Automatically, it goes to a purpose. Nigeria can adopt that, but I don't know to what extent we're going to succeed when people are still carrying cash at every point. We can also leverage on a fixed share of government revenue earmarked for tax, which Bayelsa state government is doing well on through Bayelsa Health Insurance Scheme, where civil servants pay a proportion of their salary and put aside for social health insurance. External grants can also help when the government draws a strong business case for assistance from outsiders, given the existence of public financial management safeguards, because without this, nobody's going to give you any money. Either as general budget support or targeted program funding. General budget support will come through the budget of the government, but targeted funding will come for specific projects. That is using either the sector-wide approach or equity fund option, which I will explain later. The caveat there is that a huge risk exists and has been seen in many cases where there will be crowding out of domestic funding. The Commissioner of Finance or Minister of Finance will tell you that you have got so much money already in health, and that which ordinarily comes to Ministry of Health will not come because of earmarks. They will tell you that Basic Healthcare Provision Fund has collected 58 billion already. So why are we giving you money again to Ministry of Health? That is one risk we run when we talk of earmarks. So every Commissioner of Health should be on the alert to protect that primary allocation to the ministry while also keeping the earmarks. Efficiency improvements can also help, because if you remember that World Health Report 2010, WHO recorded that 20 to 40% of health spending is wasted through inefficiency. So any attempt at efficiency gains gives us more leverage to spend for health or to consume, save money for health. We can also institute policies that discourage blank checks in program management. Blank checks sends people to take action without actually specifying what they should not do and what they should do. And what do we use to do is use explicit guidelines or standard operating procedures. Also create improvements in tax administration. VAT appears to be the global standard. Prioritizing health within government budget. This is where commissioners and ministers are called upon to put on their thinking caps and do extensive lobby to let the Minister of Finance or Commissioner of Finance to know that the investment we are making in health is not about the health people. It is the enlightened self-interest of everybody who lives in that country. The COVID-19 pandemic is an example. It doesn't spare anybody. So building up investment in health is for everybody, and they should use this to get the Ministry of Finance to do what they're supposed to do. I want to also draw our attention to the issue of Abuja Declaration, 15%. Nigeria has not come close to it. Some states in Nigeria actually came close to it in 2019, but the release never matched allocation. That is the next case. WHO data also estimate that in 2011, health share of aggregate government expenditure in 170 countries they surveyed showed that up to 12% were allocated to health. But unfortunately, in that same year, in 2019, Bayelsa state allocation to health was 2.2%. There is no way this can do magic. The impact of COVID-19 on health systems provides opportunity for ministers and commissioners of health to influence the value judgment of their colleagues in finance or the employers, the governor or the president, as the case may be. Insurance schemes, country examples. Germany is an excellent example with more than 86% of the population enrolled. Insurance is financed through general wage contributions of 16% from employers, 16% from employees. And Germans earning up to 68,000 naira can actually opt out and choose private health insurance. Netherlands, similar thing. They also share government, employers, and employees. Japan is another excellent example. Since 1961, they have been enjoying universal health coverage. And how do they do it? They ensure that everybody must be enrolled into insurance. And if you don't enroll, you pay fine. So there is a disincentive to go out of the track. As for community-based insurance, the examples we have from Rwanda shows excessive subsidy, where someone pays $1.8 per person per year. You and me know it cannot take care of healthcare of anybody. So there is heavy subsidy to subsidize community-based insurance. Nearly everywhere it is practiced, except for issues of co-payment, where you have to pay at the point of use to avoid overuse of services or moral hazard. In Nigeria and Ghana, in the review of community-based insurance schemes, lessons from Nigeria and Ghana, Christian Aid in 2014 argued that funding is a major challenge, especially in Nigeria. And for some successful schemes, high level of subsidization, as I said earlier, by government and donors is risky and raises sustainability questions. And increasing premiums from initial low levels, where you are telling somebody to pay just 360 naira or 500 naira, and you suddenly wake up and tell him that the tea party is over. You now pay the appropriate premium, bring 2,000 naira per year or per month. They will all go out and it will not succeed. So we need to think on how government can take care from the start because they have enough money with them. So the key lessons shows that a few patterns have emerged from some of these things that we have said. The success of social health insurance schemes in developed economies is built on robust formal sector, where you have so many people are working, so many people receive salaries. So you can actually deduct tax for health insurance from their salaries. And then the government pays premium for the means-tested poor, people who are really poor, and sometimes the underaged, like in Netherlands. As for community-based health insurance in developing countries, high premium subsidies raise serious long-term sustainability concerns. So these are the major lessons we have to learn, and we have to speak the truth to it. The necessary next steps, I wish the Commissioner of Health is here, but I know he will later hear me. We need to institute a proper actuarial study to determine the real cost of providing universal health coverage for Bayelsa State. And expanding coverage to everyone will necessarily require huge money. We need to know how much from the start. If you don't know how much you need for a project, you may never be able to get enough to do it. And we need to apply such data to multi-pronged revenue raising for financing the universal health coverage vision. We need to also get complementary laws to expand the health insurance net. Have we targeted regular visible income owners, people with visible income, like shop owners, tricycle operators, land and water transport operators, market women, and others? Let us look at this chart. This chart shows you that currently we have about 12,000 tricycle operators in Bayelsa. The Ministry of Transport just last week registered the 16,350th person tricycle. And if we assume that there is attrition, some of them have damaged, the first ones that were registered have damaged, some have left town. So we are left from that 16,300 to about 12,000. If they are paying 50 naira per day, they are going to generate from tricycle operators alone 15.6 million for their healthcare. And in a year, 187 million. The same thing with shop owners, the same thing with car and boat operators. So a huge amount, like 368 million, is possible to be generated if we get these people to pay these monies, excepting Sunday as a free day for them. 6 days of the week, you generate this sum of money. Why would BHIS not cover such people with ease? It is possible, but we have not tried it. Let us also ensure state's application of basic healthcare provision fund receipts through across nationally prescribed implementation guidelines. I'm not sure any state has applied those measures in full. Then we advocate for to Governor and Honorable Commissioner for Finance to progressively raise health budget from the present less than 3% in the state to something like 10% or higher, and create an equity fund within the proposed State Health Act to serve as sinking fund for financing subsidies for formal sector. Legislate multinational and big private oil companies to pay 0.5% of their annual net operating profits into the state equity fund. Make business case for domestic and offshore grants into the equity fund, and engage public-private partnerships to harness the potentials in the efficiency gains from private sector engagement. In conclusion, ladies and gentlemen, the whole process may appear too overwhelming to scare the light-hearted, but undertaking a summit of this scope is a pointer to a fact that the courage needed to follow through the reforms to success already exists within the leadership of the ministry. After all, it is often said that success happens when fortune meets preparation. Thank you very much.
Thank you, Dr. Bikeze.
I know that you will do justice to this topic, knowing where you are coming from and having worked with you for quite some time. Ladies and gentlemen, may I remind you that you may pass your questions to our second chair, Dr. Puta, and if you have comments to make, please indicate with your hand and then the mic will be passed to you. Thank you for your topic. I thank you for giving us this elaborate talk. But may I know why it is important for the state to have mandatory health insurance for all the residents of Bayelsa State? You appear to touch on it at different points in time, but I think we should emphasize it. What is the role of the legislature in enforcement and implementation of the mandatory clause of the law and the executive as well? Thank you very much. Thank you very much. I don't think there is any role for any parliament anywhere in enforcement of anything. The role of the parliament is to wait for either an executive bill from the executive or a sponsored bill from a member of the House or even an external person to come and tell the House, we need this kind of legislation for the state to move forward. Their role is to ensure that appropriate laws are made to protect public interest in the state, including the issue of insurance mandate, which Bayelsa State House of Assembly has, in their wisdom, actually enacted. So the enforcement is with the executive arm of the government. There are several measures they can take to ensure that everybody in Bayelsa is enrolled into health insurance. And we use incentive mechanisms. If you're not enrolled in insurance, for example, you cannot get certain benefits. That is the way it is done in some countries. If you don't have insurance today, you can't enter Massachusetts. So everybody who is entering Massachusetts is forced to get insurance before you enter. So the government should put on a thinking cap and use some incentive mechanisms to ensure that everybody in the state, it may not happen once, but in a gradual phased manner, everybody will be covered. It is the role of the executive. I don't know if I answered your question.
Oh, yes, it's the role of the executive, but we need also, just like you said, the executive laws and provisions to empower the necessary organs of government to enforce it.
Yeah.
So if a driver is driving past and a vehicle stops, a policeman stops him, he should have the right to ask, where is your health insurance card?
Exactly.
Just the way he's asking for the car license.
And driver's license.
And driver's license.
Yes.
So those are the things that should be on in the law or whatever gazette to ensure that these things are done.
Well, it doesn't have to be in the law. The government, after a law is enacted, has a duty to prescribe guidelines that will operationalize that law. So it is in the guidelines that operationalizes that law that you can put some of those safeguards to ensure that incentives guide human behavior to tailor towards implementation of that law.
Thank you. Thank you. Now, to strengthen the present Bayelsa health insurance scheme that we have, we know that without the formal sector, we can't go too far. The formal sector is just about 6% of the Bayelsa state population. What modalities do you think we should put in to bring in the informal sector in their numbers?
Just as I said, it's a phased program. For now, the state receives funding from the Basic Healthcare Provision Fund, from the National Primary Healthcare Gateway, and from NHIS Gateway. The money, when you put it together, may be something like 280 million. And if the state in the proposed State Health Act creates an equity fund where itself will be dropping minimum of 2% of its consolidated revenue fund, minimum of a percentage of its IGR per month, and then minimum of, say, 1 or 2% of net operating profit of multinationals in this state. and it will approach WHO. It can approach the World Bank. It can approach JICA, the agency of Japanese government, which pledged in 2005 World Health Assembly that they are ready to support any country or subnational entity that is willing and ready to move towards universal health coverage. If you don't have provisions like equity fund in your law and evidence of accountability mechanisms and public financial management systems, you can't get some of these people to give you money. But if you have such things in place, some other states, some other entities have been able to amass a lot of money from external sources. Lagos is an example. There are so many agencies in Lagos today that are putting money together for that state to build their health system. So it is a phased thing, and it is possible to get those in the remote communities who don't have any clear means of income or who don't have any payroll to come in. Remember, in 2002, there was a Bayelsa Health Services scheme where everybody was paying 200 naira to receive healthcare. I can tell you that if you raise that to 500 naira and every family is paying 500 naira, plus all these sources I have mentioned, BHIS can move to the communities. It's something we need to sit down and calculate. BHIS can move to the communities.
Thank you so much, sir, for the practical answers and solutions you're giving. I believe that our rapporteurs are taking note of all these valid points that you're bringing. Would also like to know, like we started, we're leveraging so much on what the National Health Insurance Scheme is already doing or has already done to the point. I think they got to a point where it became difficult to move on, so they opened up the gates to the states. And like the picture you painted in the developed countries, with the formal sector, we've done so well, but we've also come into the informal sector where it's so difficult to get people to come in and to expand beyond that. So I know with your vast knowledge, there are some things, because it's like, even with the National Health Insurance Scheme, there has not been so much success when it comes to community-based insurance. So I don't know what you can give us practically, because that's the phase where we are now. Like some of the points you mentioned, that giving incentives for social services, we hardly have any social services here. So like our head of marketing said in the last month, so many persons that are already with us in the informal sector even didn't pay their premium. So this is actually a practical stage that we're in. If we can get some practical things, learning from the NHIS that we can use to make sure we move beyond this point.
Let me answer it this way, very briefly. If you stand at Hillock Pharmacy, Stanford Pharmacy, and Simflac Pharmacy over a weekend from Friday to Monday, you'll find out that the amount of money spent at those patent medicine shops and pharmacies, if you aggregate them, it will pay premium of half of Bayelsa. It is an inefficient way of managing health funds. And the law can direct everybody to do the proper thing rather than going to buy medicines, ethical products without prescription. Part of the ways to save ourselves is also having prescription act. If drugs are not bought, if ethical products are not bought over the counter, if there are rules, like in nearby Ghana here, you can't buy Ampiclox without prescription. These are some of the reasons why people subvert BHIS, subvert proper healthcare system, and go and buy by themselves. It is easier, it is freer, and it saves them time. So if we have enough money, as the state doesn't have, we can actually pluck money through laws from those people, and they won't know they are paying it. If you tell Okada rider or Keke rider to pay 15 naira every day, he makes 15 naira for every drop. If you follow it up, I tell you, BHIS can move into the communities. And people demonstrate that there is quality in what they are receiving. People will tell their brothers to come, that there is a means to do operation without paying big money. So it is things that we can sit down and discuss. Thank you very much.
All right. Thank you very much, Dr. Obikeze, for answering those questions so far. Now, we would like to come to our audience. Please, I will have to note that due to want of time, If you're asking any question or making comments, please let it not be more than 1 minute. Please, let's stick to that. Thank you very much.
Yeah, thank you very much, Dr. Bikeze, for that nice presentation. My name is Professor Anthony Meribe. I'm the gross general revenue of 5.9% as regards gross domestic product. When we compute GDP, we are looking at both the formal and informal sectors of the economy, public and private. Government is the biggest spender of revenue in this country. When salaries are not paid, for example, you realize that the common market seller has a challenge. Various sources of revenue which are not properly harnessed, and they need to be harnessed and used for planning, right? Taxation, ordinarily the average Nigerian is overtaxed. Why do I say so? This case are where the industrialists, and people move from here to Ghana, move from here to Cote d'Ivoire and order to establish. Why? If you establish a small industry, you produce your own water, your own electricity, your own road and everything. All those are taxes, but we don't realize it. Even the Okada man you're talking about, you'll be surprised how much the local government councils charge the Okada man every day. From their consultants and tax people who extort money from them. We need to go back to efficiency monitoring and wastage. It's a big issue. WHO range of 20 to 40% is much more than that in Nigeria. There's a lot of wastage and inefficiency. I can give you a few examples. At the national level, for example, you remember the old support for HIV kits with the PTA, for example. Most of those kits were bought close to expiry date, and most of them were discarded and not used. That is one single example. The issue of VAMED. Some of the equipment imported through VAMED were not actually installed or used because of one piece or the other. Some of them, if you go to our health sectors today, you see some crates of some of those equipment, they are there. So we need to talk about efficiency and wastage. It's very, very critical. Now, universal health coverage, for you to have it properly applied, we have to have costed essential medical list, essential medicine list. Good enough, Nigeria now is also working on the essential diagnostic list. You put the EML and the EDL together to have the average cost per person. You can now project that. And when we talk about budget for health, we shouldn't be looking only at the national budget. We need to compute the state budgets for health and the local government budget for health to put them together. Most often from the summits we go to and talk about another, it's just the national budget. That is far away from the 15%. We need to pick up the other ones as well. Talking about funding, external funding from grants, external grants, etc. What we need is to have a well-structured Ministry of Health with a nice strategic plan to avoid working in silos. This is why programs can come into the state and work and give reports without the Ministry of Health knowing about it. If the state has a good structured strategic plan, annual implementation plan, good monitoring and evaluation, nothing can take place in the village without the Ministry of Health knowing about it. And once we collate all that, that will give us a better picture of the funding for health we are having. If we don't have that, they come in and go away without there'll be no direction. Thank you very much.
Thank you very much, sir, for that's wonderful.
Okay. Is that the last comment?
Yeah, it's just a last comment, sorry. I represent myself. Yes, I'm a co-founder of the Bamako initiative. That's why you are seeing the white hair. When he was talking, I was highly excited by listening to him because he was talking deeply my mind. What you are talking all what you have covered is exactly what we are talking about, primary healthcare or health system. Please, Bayelsa is just opening now. Fence yourself in terms of health system, otherwise they will fence you. I repeat what I am saying. This is the time for Bayelsa State to fence the health system before it's become late. They will dominate you, they will invade you where you cannot control yourself. Because the big masquerade, the sharp, they will come, you will not control them at all. They will use all kinds of influences to demolish your system. Please, this is the right time for you. This summit is not a gameplay. Me, I'm not seeing it as a gameplay. This one is the real entry point for the Bayelsa state government to build a health system where people can come and buy in. They will help you develop because you have already opened the road. The security is improving. The time the security improves, this is the time with the eat and go will come. NGOs, we call them eat and go. You understand? And they will be imposing whatever they want to you without your knowledge. Please, this is my small advice to allow you to move forward. There is one missing point, is the community ownership and the community appropriation of this system. I am not seeing it. I put it in the question mark. Please consider the community as part of the health system. We are all here seated as health professionals. We are talking, but we don't know the people who are the beneficiary, what are their key needs. We are not looking at their needs. We are thinking in lieu of lots of them to say that this is your needs. If you know your presentation, you have, where is the professor? He has said that 65% of the total population is in the rural area. One thing. The second indicator based, me, I'm listening all the presentations which have been made. You have a growth rate of 2.94%. With that two indicators alone, you see Bayelsa will be 5 million human beings in 2040. Are you getting me? Think long. Think with the time when they were saying that you have three tertiary health institutions, very good, but map it very well because it has been already an investment to know exactly which direction this one will be taking. You can even pull other people to come learn here and go back outside. That's all. It's not a bad investment, it's a good one. Think ahead, don't think today. Today your need has overcome your needs. Think ahead. Because the health insurance also is the key success for your state. Thank you very much.
Thank you very much for that elaborate analysis of. I think we want to take the final question or comments. Please, 1 minute.
Thank you for the opportunity. I'm Philomena Alade, and health worker, a retired health worker, but I'm not standing, as a health worker. Neither are my questions, related. As a community woman, as a retiree, I have a good rapport with the HIS. I've also brought down this issue before. I'm just making a concern that, it's a universal health coverage and the retirees need to be carried along fully because I'm a retiree, I'm in their midst, and I know that most of them are not using the services. I want a situation where they'll be, encouraged to come in. I've recommended or appealed or suggested that those who retire to encourage them to enter into the service because they will also drag other members of the family. Give them opportunity for a total medical examination at first so that we know their state of health. And as they progress, you know, we either yearly or 5 yearly or whatever, a repeat should be done because most of the prescriptions or when doctor prescribe for examination, most of them pay for the very high ones, and some don't even know what to do. So I'm appealing that it should be compulsory that for you, as you retire, you come for your examination and partake. Most of them are not doing that. I also want to ask that most of the prescriptions in our BHIS facilities are still out of stock. It is out of stock in some of these things that are killing the health services and making people not to go. That one should be looked into. And also monitoring the quality of the medications that are given, because I don't want to mention examples. So that is my own contribution as a member of the public and not as a health person. Thank you.
Thank you very much.
Thank you very much, Ma. At this point, I want to hand over back to my chair to bring this session to a close.
Thank you, Mr. Presenter, Dr. Obikeze. Thank you, our wonderful audience, for the time you spent on this presentation and all your contributions. We've come to know that we can improve our fiscal space through SIM tax, telecom tax, aviation tax, maybe percentage of VAT and all of that. We should be able to increase our tax drive and our tax nets. And there are several reasons we should have to increase and look for a way to expand our fiscal space for health. It's a substance we have taken, and I think we are going to do well with it. Thank you for your presentation. Thank you very much for your audience. Thank you.
Thank you very much, Dr. Agada. Please, we can give him a better round of applause. Thank you. Okay, we're moving to the next panel session. And after this session, we'll proceed on lunch break. So please, we'd like the seats to be arranged up here. Thank you. Thank you. Please, pictures, Dr. Agada, please. Where is Dr. Oputa? Okay. Thank you very much. This is plenary 4, Achieving Universal Health Coverage Through Strengthening Primary Health Care, a model for Bayelsa. And our chair is Dr. Edmond Egbe. Dr. Edmond Egbe, please. Put your hands together for him. We should say Dr. Alabo, Edmond Egbe.
We are in the plenary 4, and to co-chair this plenary session with me is Dr. Mrs. Stella Rotifa,
She's a public health consultant with the Federal Medical Center in Igwa. Can we please put our hands together for Dr. Mrs. Stella Rotifo? Our second co-chair is Mrs. Ogechukwu Ojeniwe. She is a specialist in physical therapy and rehabilitation, Assistant Director of Physiotherapy, Federal Medical Center, a member of Nigerian Society of Physiotherapy, and the head Geriatrics Group, Nigerian Society of Physiotherapy. Can we please put our hands together for Mrs. Ogechukwu? She will be standing in the audience and also acknowledge those who will have to ask questions, that we can take down the questions and save time. I also want to welcome our audience that are online. In case there are questions to be asked, we also want you to put those questions through to Mrs. Ogechukwu Ojenwe. There are also rapporteurs. There are also some rapporteurs that are on the background, and this is led by Dr. Lembo and Dr. Okoye. Good afternoon, ladies and gentlemen. Welcome to this session. And we're looking at universal primary health care, strengthening universal health coverage, achieving universal health coverage through strengthening primary health care, a model for Bayelsa. We know that this is a topical topic now. And we want some experts to tell us what to do. So I'll be introducing some of the experts who will be speaking to us. I want to call to the podium Dr. Martins Amekepriye Bekesu. He's the Executive Secretary, Bayelsa State Primary Healthcare Board. Please, can you come to the podium, Dr. Bekesu? Sorry about that mix-up. We just received the information that instead of Dr. Bekesu, Dr. Priye Aganaba, a member of the board, the former director of private healthcare department of the State Ministry of Health, to be speaking on behalf of the board. Please, can we welcome Dr. Aganaba to the podium? Also to be in this panel, we'll have Mrs. Happiness Massa. Mrs. Happiness Massa is the Director of Community and Child Health Services in the Bayelsa State Primary Healthcare Board. Please, can she be welcome to the podium with a round of applause? Also in this panel is Dr. B. Dieng. He is a Gavi consultant, and he spoke elaborately at the last session. Can we welcome Dr. Dieng with a round of applause? On this panel also is Dr. Awuva Oseri. He's a seasoned medical practitioner with over 30 years experience in clinical and public health. He is an immunization and health system expert with vast experience and advocacy for resource mobilization and coordination of public health interventions. Can you please welcome Dr. Oseri to the podium with a round of applause, please? I'll hand over to my co-chair to do the remaining introductions of the panelists. Well, to welcome to the board is Dr. Eke Abe. He's standing in for Dr. Tushan Rane, Chief of Field Office, Rivers Field, UNICEF. Dr. Abe, please. Is Dr. Abe in the house? Okay, you're welcome, sir. We also want to welcome to the panel Mr. Odoko Joseph. He is the Deputy Provost, College of Health Technology,
Mr. Doko Joseph. You're welcome, sir. Also like to welcome as one of our panelists, Mr. Obaro Ologbo, the State Coordinator, National Health Insurance Scheme. Mr. Ologbo, please. Oh, okay, I learned he's been replaced. He's been represented by. Okay, thank you, sir. Yeah. So I also like to welcome Dr. Angus Ikpe. Dr. Angus Ikpe, you're welcome to the panel. Is Dr. Angus around? Dr. Angus Ikpe, please. Okay. Dr. Angus Ikpe? Okay, yeah, he's coming. Thank you, my co-chair, for these introductions. And can we all please welcome the panelists with a round of applause, please? Don't worry, lunch is ready. We'll soon be done. Yeah? So I want to start the ball rolling with Dr. Priye Aganaba, who has also worked in primary health care, Donye Aganaba, who has also worked in the primary healthcare space for a while before retiring, and also a member of the board. Dr. Aganaba, what has been your experience working to increase community involvement in the primary healthcare system in Bayelsa State? You have about 2 minutes to respond to this, please.
Well, thank you very much. Community involvement is a very key aspect of primary healthcare, also sometimes called as community participation. And it's actually embedded in the definition of primary healthcare. We have found that if the communities, which is not just the people living there, communities include the traditional leaders, the religious organizations, CBOs, the recipients of the healthcare services, and other persons that are stakeholders. If they are not involved in the healthcare delivery strategy, and they do not see it as theirs, if there is no ownership, they don't have they don't accept it and give their full support to it. There are times where if the community doesn't believe that you are bringing a health center for their good and tell them you want to build a health center and they don't believe that's what they need, they will show you one end of the community somewhere where nobody will be able to access at midnight to build your facility. But once they see it as their project, the community will show you where a choice place where you can build the facility for them. So it's very important. They have found that if the community does not own the program, they will not give in their full support. So many things have to be done to involve the communities. Over the time, efforts have been made to involve the communities in activities. Sometimes, like in the maternal care, to reduce maternal deaths, and so they have started some activities like involving communities in the distribution of misoprostol and cloexidine, and that has helped to reduce maternal mortality and perinatal mortality in some places. So it's very important for communities to see that. Even in the talk about health insurance and community-based health insurance, we have seen here that the formal sector was kind of forced in to be part of the health insurance. But for the community-based health insurance, there are problems because they don't see it as their program. The planning, they were not involved in the planning. They were not involved in conceptualizing what should be done. The needs were not assessed. So until community sees a program as theirs, they will not give their full support. And over the while, so many efforts have been made, like now forming the chiefs At another time, they formed the corps, community-oriented resource persons, and so on. And at such times, the programs had improvement, but those programs have really not been sustained because they were seen as donor programs and not community-owned programs. So the communities did not make efforts to continue funding them. And as long as they don't see it as a program, they will not support the program fully. Thank you.
Thank you, Dr. Ganaba, for your thoughts. Thank you, Dr. Ganaba, for your thoughts. This is just to remind all of us that you can jot down your questions and your comments. The topic again is achieving universal health coverage through strengthened primary health care. A model, we're trying to create a model for Bayelsa. Now, it's your turn, Mrs. Happiness Massa. You're the program manager, State Emergency Maternal and Child Health Intervention Center for Bayelsa State. Ma, please, can you kindly share some of your initial thoughts on your experience with the emergency coordination mechanisms in Bayelsa State, the centric and the seric, and how they have played out? We know you are vast in experience. Please, can you kindly share that with us?
Okay, thank you, moderator. Before I go into my experiences, I just want to give a little background about the emergency coordinating centers of the Bayelsa State Primary Health Care Board. To say the fact that we are in an emergency is but an understatement. Why do I say that? Because if we are very attentive from yesterday, we will have understood that the numbers of women and children that are dying calls for an emergency. I want us to look beyond the numbers. Let's look beyond the numbers, you know. When they say 145 women die every day, we just look at it as a number. Or 2,300 children die every day. We just look at it as a statistic. But if you put yourself in the shoes of the family, the community of those persons that are dying, you need to know that we are in an emergency. And that is why the federal government of Nigeria, in their own wisdom, in the year 2019, April 8th, declared a state of emergency on maternal and child health deaths. That led to the establishment of NEMCHIC, which is the National Emergency Maternal Child Health Intervention Center. And these centers were now, you know, scaled down to the states, those states that have very poor indices and the LGAs. Bayelsa happens to be one of the states in the South-South. Of course, we have seen data. Our indicators are one of the worst in the South-South. To say it, we have to say it. If we want to talk about our skilled birth attendant, real-time data, if I tell you, you'll be shocked. Not to talk of our CPR, not to talk of our ANC, not to talk of all other indicators. So as a result of that, we have what we call the BY-SEMCHIC, which is the Bayelsa State Emergency Maternal and Child Intervention Center. And all we do there is to galvanize stakeholders' engagement and coordinate them at the primary healthcare level. I'm emphasizing it, the primary healthcare level in the RMNCAH+N space. So we have our goal. The goal is that by 2021, unfortunately we are in 2021, we're looking at reducing maternal mortality rates by 50%. Unfortunately, like I said, we're in 2021. Then we have our vision. The vision is that no woman should die of preventable causes. No woman should die. That is the vision the center has from the national to the state to the LG. Then our mission statement is to create awareness, because most times people are not aware of this fact. So we want to create awareness, especially at the community level, and also to ensure emergency response in cases of these deaths. So that is our mission, vision, and goal for that center.
Thank you. Thank you, Mrs. Master. Dr. Dieng, it's your turn now. I have sat under you in some teachings and some innovations to guide primary health care. SEMCHIC, CERIC, they are all programs of emergency. Can these programs be integrated? How do you think we can avoid verticality amongst these programs and strengthen service delivery as an integrated package so as we can have a minimum service program package for primary health care at that level? Thank you.
Thank you very much. I think this one is part of the real aim of having an integrated service package. But you know, sometimes we are donor-driven. You have the vertical program which comes, and you have the integrated one, and for those one, you don't have enough money for that purpose. That's why if you look at the literature talking about integrated program, the benefit and the added value, it's very difficult to find a literature on it. Recently, Nigeria has been the first country which has integrated like campaigns. Instead of dealing with this vertical campaign, measles today, men are free back tomorrow, yellow fever after tomorrow, and so on and so forth. With the guy who is sitting just at my left here, he pushed for making this one happen in an integrated manner to save funding, save time, save human resources overutilization at the grassroots level. Because each of them, if you take the polio program, it uses a lot of human resources, takes a lot of time, it's demolish the whole health system at the grassroots. And because it's a priority for eradication, but linked to the time, if it's for a short time period, we understand, but for a long time period, like I so-called the HIV/AIDS program, you see, it's a monster within a monster. It's highly funded, but sometimes you don't know where the funding is going, how to utilize the funding, because at the grassroots level, there is no system, there is no say to say, this is the funding, where the funding is supposed to lie in, and to integrate that funding with other health services. Having said that, I think, as I said earlier, this is the golden opportunity for Bayelsa State to say, this is my primary healthcare package. Listening yesterday priority by the Honorable Commissioner for Health, I have understood that HIV and AIDS is part of the priority of the priority. Take it. Take immunization as priority of the priority. And you take the two, they will be the locomotive of the whole primary healthcare system. With that one, you make other program to buy in for you to move forward, to know exactly how to develop a package which satisfies the real rural communities, the one at the creek there. And you develop also a system where you see, if you utilize what is existing in Rwanda, I have been in the whole African continent, just to let you know, I know each of the corner of the continent. My last time here is in 2009 when the President Yaradua, late Yaradua, came here. We were the first mission who came here to see how to do and what to do. But just to tell you, you have gone far. There are a lot of positive changes. But use this one as a golden opportunity to build the system, to fence it again. Before this vertical program, you see, malaria will come to say, we need our program today. HIV will come our program today. When you have your whole program, everything is put in a basket fund, it will yield to a positive result. Thank you very much.
Thank you very much, Dr. Dieng. It's now your turn, sir, Dr. Oteri. You are the immunization advisor, Nigeria Governors Forum. Sir, we want to have your thoughts on how we can leverage investment in immunization, in the immunization program for broad health system strengthening. We want to have your thoughts on how we can leverage investment in immunization program for broad health system strengthening. So your thoughts, sir.
Thank you very much. Okay, fine. I will just go back a little bit of history. We all know that immunization is one of the earliest components or one of the components of PAC at Alma Ata.
Sir, can you speak louder? We can't hear you clearly. Maybe.
Okay, thank you. Like I was saying, I said, if we go back to history, when Alma Ata was declared, immunization was one of the components of PAC. And we all know that immunization is one of the most cost-effective public health interventions. And we also know that it is one of the interventions that is well-funded, both globally, internationally, and even nationally. And this has caused a lot of problems, which made it look as if it's a verticalized program. And from 2006, when the immunization world decided to do a 10-year plan, which was the GIFs, one of the components of it was integration, where interventions are integrated with immunization so that you can get better performance. Then apart from that, when the decade of vaccine, which was their next 10-year plan, which just ended, PAC and immunization was also brought together as a single component. Then in the current Immunization Agenda 2030, you notice that it is mentioned that intersectionality of immunization vis-a-vis health programs and not health programs is a contributing factor to achievement of SDG and universal health coverage. So it was well documented there. So at that level, they started moving from that living immunization on its own. In 2006, when Gavi brought the health system strengthening, they realized that funding immunization alone without funding the health system cannot take you to the promised land. So they brought the HSS, which most countries applied for. And there they're not looking at immunization as a specific disease, but they're looking at other targets, other things that could be done. Training, resource, health structures, and the rest were put together. Then, so a lot have changed. Before, those of us that were in immunization early know that what we're using as a monitoring tool was DVDMT. DVDMT was specific for only immunization, but that has been pushed aside. Now we are doing DHIS that captures virtually everything. So these are areas where they're trying to look at how best to leverage on those opportunities. Then recently they did a Seattle declaration in Washington. That was between NGF, Nigerian governors, MPSCD, Bill and Melinda Gates, and Aliko Dangote Foundation. And one of the things we were checking is PAC under one roof. So if you can put all those things together, then you can be very sure that all the resources that—
Sorry, sir, excuse me. Please, can we stop the noise in the hall so we can hear what they are saying? Thank you.
So like I was saying, the Seattle Declaration addresses PAC under one roof, which is a very key component. So you cannot say you want to strengthen the system when you still have verticalized structures. So the PAC under one roof addresses PAC generally without looking at little components. There are some states in this country that all the workers in PAC are in that primary care board, primary care agency. From the ES to the least worker in the local government area, they all work under that PAC. In that way, you can discipline them, you can train them, you can have their programs going as it should go. But when you have a situation where the primary health care board is created, the workers in that board are governed by either local government or Ministry of Health, they're not going to get the best out of them. because you cannot discipline them. So those are the things that we need to change. That, okay, before we used to have Project Task Force on Immunization. It has stopped. It's now Project Task Force on Immunization and PAC. So when you have those kind of things, it works. So for states that have done well, if you look at Kano, Kano is coming from where Bayelsa is going. Kano had MOU with Aliko Dangote, BMGF, and the rest. So they warehoused virtually all the funds meant for PAC in one basket. And as soon as that support ended, the state has been able to pick up what it should do. So they've warehoused everything. There are some meetings to go for. When you hear Kano State mentioning the amount they get for their program, the primary care agency, you will weep, because what they get in a month is what some states get in a year, because they've already started that implementation of the PAC under one roof. So those are the areas we can look at. Then a lot of things have actually come in from immunization. GIS, use of GIS, micro planning. Those are things that the other larger PAC can actually use to strengthen their program. The cold chain equipment, those are all, the solars are things that came through immunization. They cannot be duplicated to use to provide lights for the health facilities at that level. In that way, you harness virtually all the gains of immunization to support your larger PAC. I'll stop here. Thank you.
Thank you, Dr. Terry. We believe your closeness to the Nigerian Governors Forum will help to push for these service delivery points to be effective at the primary healthcare level. Dr. Egeabe from the UNICEF Field Office in Rivers State. We've been through these processes together in Bayelsa. The sawmill support for immunization saw our indices rise. And after that grant ran over, we saw our indices coming down. Do you think that through this service delivery under one package, leveraging on every other thing put together, do our care workers have the capacity to use this system to strengthen service delivery under the package called Universal Health Coverage?
Hello. Thank you very much, Chair of the session, and good afternoon. Like as I said, we had it a bit good, and now we're having it bad again in immunization in Bayelsa. And you have coned it down to whether the quality of the capacity building we have given to the health workers at the PAC level is adequate or not adequate. You know, the way I look at it, the capacity building for health workers, we cannot ever overemphasize the need for it. But we have to also talk about the quality of that capacity building. You and I know that we have had some challenges, both at the macro level, the system level, and at the micro level as it affects the facility itself. And as well as us not having that feedback, that community ownership. Because if we have health workers that are trained and they also have some form of assessments and feedback from the community, then we're always at all times going to put them on their toes. And then two, who are our health workers that we are training? Are they employed health workers in our system? If we don't have them retained in our system, then we cannot achieve much because they come and go. What we achieved that period was we had a lot of volunteers that we're using. But right now, we don't have the capacity to either utilize those volunteers or pay them probably. But then we had them. They could track our babies. They could do a lot of tracking in the communities. They know their communities. We are not able to do that. So the first thing I would suggest is the states, and luckily, thank God the commissioner is here, they have to create that enabling environment. They have to, number one, make the health workers be adequate in number. make their health workers be adequate, even in their own competency, as well as the skills that is needed. Because every health activity has specific skills and skill sets assigned to it. A doctor cannot do, a nurse cannot do the work of a doctor, just as the community health worker cannot and may not be able to do the work of the nurse and the doctor. So for all our health facilities, we have to have all this. And then we now come to quality of training. I will also emphasize that we have to try and decentralize our trainings. We have to put in measures for supervision and monitoring of our trainings. Trainings that are at the state level, you see the quality might be good, but when you take it to the LGAs or the wards, and you don't have supervisors going from the state to the LGAs or to the wards, you see that it is always watered down. And that's all we notice when we go for our monitoring of our activities, of immunization sessions. You see that what you thought ordinarily they are imbibed, they are doing the wrong thing. And that is because the quality of training at that level was not as high as the quality of training at the upper level. So I rest my case on that for now. Thank you very much.
Thank you very much, Dr. Abe. You have spoken extensively on that. Now, Mr. Odoko Joseph. Sir, you're the Deputy Provost College of Health Technology, and you have been helping us produce the secondary level manpower. What are your initial thoughts on how we can increase production and quality of human resources for health towards achieving universal health coverage?
Right. The chairman and the co.
Sir, you need to speak louder since you have the face mask on.
One is my experience. Yes, my experience in primary care from the local government area, taking me to the College of Health Technology, where we produce these primary care workers, is based on the ground of the foundation interest of bringing up primary health care, getting out staffs that will actually implement the primary care program. Because primary care is talking about availability, affordability, and the rest to the people in the community. So in College of Health Technology, in terms of increase of production, right from the aim of creation of that under primary care, we have been able to produce, as I'm telling you, College of Health Technology, Bayelsa State here, from 2009 to 2020, we have produced community health per se up to 1,100 staffs. And this product are already posted to various health centers for some years. And after some years, a good number of them are yet to be employed, like what my presenters have mentioned. And you find them as volunteers. And when they are volunteers, the impact is not there. More so, the increase of productivity of these members is still ongoing. Every year, there are admissions that is going on. But the painful aspect of it, with this 1,100, we have them on ground. They are yet to put themselves into implementation in the system. And now we're admitting more. So the increase of the manpower is ongoing. The quality of it too is actually ongoing. But the bitterness of it is like the secretary of the primary care board mentioned. Most of the facilities are empty. The doctors we are having today, their level of performance is expected to be at the tertiary, at the secondary. While at the primary, it's expected that this product we are having supposed to be the one that have understanding of the community and tell about primary health care and the acceptability of it. So that at the end of it, they can bring them down. One of my cardinal experiences I experienced in the product of this product in primary health care, I work with my mentor, Dr. Ganaba, who were going from community to community to do immunization because I'm a community health worker. Today, I am a resource person producing people. But where are these people going to find themselves there? A lot of things we have discussed here. The target we are talking is we want to take doctors to that community level. Why already we have the manpower? And at the community level, just like it's a public health expert, if one doctor is a public expert goes there and you have 2-3 community health persons, they can enter into interlab. We go for outreach programs and this same product. So the summary I want to put in is College of Health Technology is producing community health workers, environmental health officers, pharmacy technician, med lab technician, dental surgery technicians. It will be of interest to you to note, it happened in Sabama, where we have outbreak of diarrhea diseases. This outbreak of diarrhea diseases, we need to now call the environmental health officers to now find out what is the cause. And we discovered that one of our participants mentioned, we poo in the river, we drink from it. And that makes poliomyelitis to be very common. And this community health and environmental health people were able to go in and have a meeting with the community members. When they had the meeting, they accepted to now have their toilet system of the improved one. And it cut off for that outbreak of these cholera cases and the rest. So increase of productivity as far as College of Health Technology is concerned and other states, because we have 36 states, and these 36 states have this College of Health Technology. And this College of Health Technology are producing this primary healthcare manpower at the grassroots, where the people understand them and accept. By the time implication will come, already they have referred the case to the doctor that is already waiting. So the increase of productivity, I think, is already ongoing. The only problem we are having, I'm using this opportunity, now that we're having this forum, the emergency is actually needed to recruit these people so that our increase will not be in vain. They are training people. I've had contact with some of the graduates of those schools, like what they have mentioned. So they are disappointed in the system. They are using them as volunteers. After using them for volunteers, what is our expectation? So it is better we package something to say that there must be retention. After your training, I benefited from primary care program by Ransom Kuti. Immediately, I was recruited into the College of Tech. I was on in-service training. Then immediately I graduated, they posted me, and my interest is to go to the rural area. So these people were training them. Our mindset or focus was given to them that you have to go to the rural area. But after graduation, they are not in the rural area. So by the time they get used to the urban area, when you post them to the rural area, the same thing applicable to any human being. They will not like to go to that place. So my input is immediately these people graduate, the package should be made in a way that you are posted to this area. And they'll be interested to go to that place. A gap that is created will turn to a product to affect us. Thank you very much.
Thank you very much, Mr. Joseph Idoko. You have given a synopsis of the problem of the workforce, the health workforce in Bayelsa. Of course, government wants to employ, but all the time, or most of the time, the challenge is resources, money to pay salaries. Now, that brings me to you, Mr. Jesse. You have the health insurance scheme, the Assistant General Manager. Yes, Nigeria Health Insurance Scheme. How do you think insurance can play a role in enlarging our health workforce? We have the Basic Healthcare Provision Fund. Currently, we also have the Bayelsa Health Insurance Scheme. Is there any way this can help to strengthen the services at the primary healthcare level, especially as it concerns our workforce?
Thank you very much. Thank you very much. Thank you so much, Mr. Chairman and Co-Chairman. I bring greetings from our Executive Secretary, Professor Mohamed Sambo. Yes, NHIS can partner with Bayelsa State on health insurance issues. First of all, let's look at the mandates that we have as, as a body, NHIS. The mandate is universal health coverage for all Nigerians. We have to cover all Nigerians. Provide mandatory health care, affordable health care, then easy access to health care for all. Today,
the Bayelsa State Health Insurance was created because NHIS, in synergy with the state, ensure that it's, emerged, which today we are proud of. And the state, NHIS, introduced in line, with the basic healthcare provision fund, which they have created. NHIS got that creation from the National Health Act 2014. The basic healthcare provision fund, which we talked about, is to help states, particularly in the area of primary healthcare centers, so that they will be well equipped and improved. Just recently, last week, NHIS, in conjunction with Bayelsa State Health Insurance, we had accreditation of the primary healthcare centers, which I also participated in that accreditation. We went to so many centers. What I discovered from that accreditation is that most of the primary healthcare centers are not up to date. They have dilapidated structures. But with the basic healthcare provision fund that will come in through us, NHIS, it will increase funding in the state, which is already ongoing. And I'm, appealing to the state government of Bayelsa State to ensure that health insurance becomes mandatory in the state. If it's made mandatory, I know for sure that today, as we speak, the formal sector of Bayelsa State has already keyed into it. But with the act, a lot of Bayelsans will key into it. They will come in, get registered, and participate in health insurance. That will go a long way in helping the state. And more so, NHIS, in partnership with National Primary Healthcare Center and Bayelsa State Health Insurance, NHIS and National Primary Healthcare, they are the two gateways for this basic healthcare provision fund. They are partnering with the state so that the primary healthcare centers will be improved. And once these primary healthcare centers are improved in the state, a lot of people are going to benefit. Bayelsans will benefit from it. So today, NHS has not left Bayelsa State, as in they are there to help them. They are partnering with them in so many ways, which I just mentioned, the basic healthcare provision fund. So I believe with the fund provided by us, NHIS, we urge the state, or we are appealing to the state government to provide a 25% counterpart funding, so that with the money we are bringing and the state brings their own, there will be a lot of progress in health insurance. Thank you very much.
Thank you very much for your thoughts. Now, it's your turn, Dr. Angus Ikpe. I know you are involved in strategic planning. Now, with your understanding of primary healthcare as a pivotal for the achievement of universal health coverage, what strategic plans are in place to strengthen PHC in achieving equitable care? That's part A. Then part B to your question, sir, is what strategic plans are in place to strengthen primary health care under one roof? Thank you. Do I take it again? Okay.
Okay, thank you, Dr. Rotifa and Dr. Edmond Igbe. Well, you will permit me, by virtue of my role in this summit in supporting, because we were from the Federal Ministry of Health, came in to support the states in the summit and as well as further development of strategic plan that will take place. I would want to, I would answer your questions, but I want to try to do an overview because I know that in discussing health system strengthening is usually not a very lucid conversation. And the best way to go about it is to take a broader point of view of it. That is to say, you don't just start looking at the micro elements, but you look at it from a broad perspective. And in that way, you should usually want to base it on evidence or on expert opinion. Okay, and when you talk about health system strengthening, there are recommendations for health system strengthening. We know about the health sector control knobs, which they expect us to adjust. In adjusting those health sector control knobs, you will be able to make a change in the health system for improvement. And you see, Bayelsa State, as a state, has, it presents an opportunity to have a model health system that the rest of the country would want to follow. Okay, so if you look at determinants of health outcomes, you can, from the point of view of the health problems, you have intrinsic ones, you have extrinsic ones. The intrinsic would include genetic factors. Outside, you have physical environment and social environment. And health services in itself is part of the social factors that determine health outcomes. And so the factors that determine the health sector or health system factors that determine health outcomes, they are what you call, as in they are, not all of them, they are key ones that help you to bring about improvement. Every aspect of, the components of the health system, okay, being the building blocks are not quite represented there. You have three basic areas or three groups, more or less. One of them is healthcare financing. The other one is organization, and the third one is what you can call compliance. Breaking healthcare financing, you have funding and you have payment mechanisms, and breaking down compliance, you have regulation and you have persuasion. Now, if we don't look at it from a broad point of view, we'll keep coming up with all manner of suggestions that are supposed to, that we're supposed to look at, and the list might be so long. And then one other thing we need to also consider is the fact that you have to prioritize, okay, the solution to your health needs. You cannot have a lot of memoranda and proposals have come up here, a lot of suggestions, but you have to prioritize. I will just go by these three health system control knobs as a guide to improving. They are saying that you mustn't adjust all of these knobs, but you may need to adjust probably one or two. Sometimes you need to adjust all. You may also adjust all of them and you won't get results, okay? But you need to focus on them. I want to thank Dr. Obikezie, who gave us the talk on, I think he covered healthcare financing. That's an area, when he started speaking, was when I felt that we have started this discussion, because from an expert point of view, you begin to know what is required to be able to make change or bring about improvement in the health system, okay? First of all, in financing, in the funding, you would have, today there's a debate on whether we are going for general revenue as a means of funding our healthcare system, or we should go with health insurance. And usually in every country, it's usually a mix. It's just that you might have what is predominant in one country is different from what's predominant for us. We have chosen, the policy is through health insurance, through social health insurance. We are not going through the general revenue, which is another means, which is actually being proposed in another reform program today, where we are supposed to turn our system into a single payer tax-based system. We are supposed to dismantle the entire health system we have today. NHIS will cease to exist, and we have a unitary system that is isolated from the political system to help us. That's what you have in the UK, which is the NHS. You also have that in Brazil, the largest single payer, health system that you have. Now, if you go down to the payments, the funding system, we're saying we're going to do a mix. Predominantly, we're looking at funding through social insurance. So what should we be doing? We should be looking at expanding that. We've been talking about Bayelsa State Health Insurance. Bayelsa State, as far as I'm concerned, is a step ahead of the country because they've been able to get a law that makes health insurance mandatory. What we're now discussing, some persons asked Dr. Obikeze that question, how do we ensure that it is enforced? Because that's where we are. And he had given suggestions, okay? One problem we have in our country is that the regulatory agencies, they are not effective. That's the problem. You heard from him. Enforcement, apart from the fact that you could state penalties in the law, you go on as a regulatory agency or a regulatory body to come up with guidelines that will help go about this enforcement. Regulatory agencies are not funded. These are things we're supposed to be. I wish the Honorable Commissioner was still here to listen. If we want to get it right, I will still get to regulation. But one thing we should do now is to take the healthcare financing to bring it, to make sure we improve on our coverage of health insurance, is to go on to enforce, mandatory health insurance first within the organized private sector. What you have here is just the public sector that is involved. You have the organized private sector. You often interact with them. There are easy ways to go about ensure that health insurance, covers the organized private sector. Then you have the, informal sector that is, you can reach them through groups. They have associations. They have all manner of groups. You heard about, Dr. Obikeze went a long way. I don't need to go too far with that, but he has given the recommendations. If the rapporteurs were listening and taking note of what he said, he has covered what needs to be done. So I'm saying that take it beyond the level of, you have gotten the mandatory health insurance as a law. It is now time to enforce. And then you should put on your thinking cap and look at how to engage the informal sector. Now, there's still a group. That's why I say it's always a mix. There is a group that you probably cannot ask to pay premiums. And that is the vulnerable group. And that is where you have your BHCPF. Even though I feel that the BHCPF is over.
Dr. Angus, please, can you kindly round up?
Okay, I'm going to round up. Probably I'll just stop at health and financing. BHCPF is overrated because at the end of the day, how much we get to these facilities? Now, I think Bayelsa State should go for something else, which is something you have in River State, but the approach should be different. Apart from BHCPF that will go to River State, the River State system has the primary healthcare board law that mandates allocation of 10% of local government allocation to primary healthcare to be managed by the board. For me, they've not even been able to implement it. They went from 3%, they are now working with 5%. But in order not to also abuse that fund, you would want to take that fund to operate through health insurance. Because when you leave for the board to just manage, the board might decide to start putting up buildings, buying equipment that are not useful, repainting and renovating buildings while they're supposed to use to provide health services in the health center. So they should use it to purchase health care for the vulnerable. Bayelsa State can go for further laws, further legislation to ensure that local government funds, including state funds, have an allocation. You would usually protect these things using legislation. Let me just quickly talk about organization, which is another very important aspect.
We are running out of time. So in another 30 seconds, can you just wrap up your
Okay, but just simply in organization, you see, it's about who does what. But most of the time when we discuss organization, we don't really understand who does what. What's the organogram? First of all, are we following the principles? You have the macro organization as in the institutions and so on. You have situations where there are duplications of functions. You have situations where the reporting line is not clear. First of all, we'll make sure we're clear, we make sure we comply with principles of management. Unity of command. Nobody should report to more than one superior. Okay? Again, you must have the chain of command should not be too long such that it becomes difficult to carry out something. For instance, in some systems, at the health center, they make money to spend the money, they have to do a memo up to the primary healthcare board for approval before it comes back. By the time it comes back, there are no drugs in the health center. That's a problem. So you want to improve on all that. Your span of control. You see one person supervising 24 local governments. It doesn't make sense, not possible. Span of control, you shouldn't do more than 6 subordinates. And then let me just talk about the shortage of health workers in the state.
Thank you, Dr.
You just
Angus
want to,
Igwe.
just this last, you just want to,
Thank
the
you,
stopgap
Dr.
measure
Angus
that
Igwe.
can be used right now is to go for contract doctors and nurses as a stopgap measure while you wait for your sons and daughters to come up and take up the employment. Those are things that you can do. There's a lot, we'll still be working with the planning team here, so we'll probably continue discussion there. Thank you very much.
Thank you, Dr. Angus Igwe. We'll need to consult you more for more of our strategic plans. So we're rounding up, having a final thought. Mr. Ujane Obi Jesse, please let's have your final thoughts on achieving universal health coverage through strengthening of primary health care, a model for Bayelsa State. Your final thoughts, sir.
Thank you so much, Co-Chairman. My final thought is this. I want the state government, the informal sector is well encouraged. The groups that we have in the states, if the government encourages them to key into Bayelsa State insurance, a lot of people will be covered in the state. Thank you.
Thank you very much, Mr. Oyane Ubi. Yes, sir. Mr. Odoko Joseph, your final thought in 2 minutes, sir.
My final
on
thought.
achieving
My final
universal health
thought.
coverage.
Already having that issue whereby our prayers is let the state government employ the one
and Mr. Dogo has raised an issue. You are also the member of the board. Now, he's talked about sanctions to health workers who are trounced. What can your board do in your own capacity to ensure that health workers stay in their duty station to offer service at that primary health care level?
Why are you scared of me? Okay, thank you very much. My final thoughts concerning what you just said now, discipline of staff. Let me pull this thing here. About a week or two ago, there was a report about a sick person going to one of the facilities in one of the AGs, and they didn't meet any health worker. So through community structures, they released information. The information got to the board looked at it, asked people to review it, and then called the AG authority and asked the directors there to investigate the case. And the persons have been giving queries. So that's one thing they are doing to try to regulate that. Then also my final thoughts. You see, I believe that planning is not too difficult if you have the structures. One of the things that they always say is that Nigeria is full of plans, but very poor in implementation. And that's the bane of our problem. Very poor in implementation. Why? Because sometimes, like my UNICEF friend here, they come and give us money in the States, carry out activities, vertical activities, and go out. They don't build capacity. I remember sometime in 2001, WHO started this disease surveillance training of focal persons. I was involved in the process. We went around the AGS, training focal persons, and some of them are still working till today. We got DSNOs. And they also set up a structure of monitoring their activities. The focal persons report to the DSNOs report to the state DSNO, and the state DSNO reports to the state epidemiologist. The structure is still there and is funded. So when avian influenza came, they just added it to the diseases they are reporting. And when Ebola also came, because there is a strong disease surveillance system all over the country, it wasn't a problem to Nigeria. The same thing with this. And some of our staff, WHO staff and so, were sent out of the country to Senegal, to other West African countries to help build their system because structure. So one of my suggestions is that we should focus on structure. We have this, and it's funded. WHO, I believe, is still funding them till today, since 2001. But here, the immunization personnel, I don't know whether you've included them in there. Okay, they are funding them. I don't know whether it has stopped. You see, what about the reproductive health, family planning, the persons at the local areas, the TB leprosy program? You find that sometimes you even ask somebody, what are your indicators? And they don't even know what the indicators are. Or they will say our coverage is 30%. So what are the structures you are using? The WHO decided to do active surveillance, not passive surveillance. So what are we having in the rest of the systems? So my suggestion is we should strengthen these structures, not IPDs, NIPDs, and so on, and not campaigns. We should come down on these campaigns and focus more on the structures. Concerning plants, the PRS department can liaise with the Ministry of Health and domesticate all the plants. We can draw up, get Federal Ministry of Health to support us to draw out all the plans that we need, all the policies, child health policy, immunization policy. We don't even have immunization policy in the state. We can draw up all these things. I talked also, I know FSI 260 has tried a lot to work on the DHIS2 system, and it's functional. We have a reporting system where they report from their facilities. It goes straight into the cloud, and the Directorate of PRS in the Ministry of Health has those records. So for partners, support us to draw structures. And then come down on vertical programs. Let's strengthen our system. Concerning ownership, the ownership too, during the days of the Babangida and so on, there were these village health committees, world health committees, and there was this Baraka Initiative program, and some of them were somehow funded with that seed money they gave to them, and they were funding them. But after a while, when that program stopped, also with some PTF support, it all died down. So when you go back to this system, we have also again tried to put up the village health committees and the world health committees and the facility health committees, but funding has not been regular. So either state has to take up these fundings or some partners have to support us. Then concerning partners, there are some states that have 10, 20 partners working with them. They have Boko Haram, they have herdsmen, and the partners are still there. But then here, they hear of sea pirates and they say they are not coming. And this is where they get the oil. So the Federal Ministry of Health should also, our commissioner has said they are working on controlling the security system. So I believe that the Federal Ministry of Health can also encourage some partners. FHI 360 has done a lot here. PACT was also supporting, but when they left, our malaria control program is not very much on to now in terms of funding. Then the SDGs, I remember a time we drew out some plans with the SDGs, and they purchased and filled our state with ACTs, filled our state with LLINs that took us more than a year to distribute to the health facilities. Since after that time, none has come up again. So there should be integration of these activities so that they should look at what the bottlenecks are and what should change our indicators and not put action into this.
Thank you so much.
I'll round up, please, man. Here now too, we are talking about this, the control of minor ailments and diseases. It's only one component of primary health care. We're not talking about all the other components. So I think that these also should be strengthened. Then at the facility level, trainings, as somebody has said, shouldn't be only at the state level. It should go to the AJ level and to the private, health facility level. Then workers should also, like some partners do, I know partners have their itineraries before the end of the next month. You have an itinerary for this month, and you work on that. And these are models. So why can't states develop itineraries? So all the state officers too, they should be trained on how to develop the itineraries and get itineraries to work. Then finally, community participation. Here now, we are planning. We've been told that people comply more and own programs more when they are involved from planning to implementation, right from planning. So in our planning to next time or in subsequent meetings, let's invite the traditional rulers. They shouldn't only come for the opening ceremonies. Let's invite the religious leaders. They may not have something to put in. Let's invite the CBOs and let them also be among the panelists, not people that will just listen to us. I can talk for the next 1 hour, but
thank you very much.
Just want me to talk.
Thank you for not talking for the next hour. Thank you. Just to the audience, please, you can write your questions, your comments, and give to Mrs. Oge. So, Dr. Abbey, I know you are very vast and you've worked so long with the UNICEF. Now, what are your final thoughts? So many points have been raised here from Mr. Odoko, health workers not staying in their places of work. We also know that sometimes those peripheral communities are not so conducive. They don't have good facilities, no good schools for their children to attend. Some places they can't make good phone calls. So some of those, and then Dr. Kanaba has also talked to us about community participation. We know that community participation is a very strong pillar in primary healthcare. We can't talk of success of primary healthcare without good community participation. He has also said UNICEF come, they give them money to conduct capacity building, but maybe it's not properly implemented, maybe it's not properly done? We don't know. How else can UNICEF, what else can you do differently? Can your organization do differently to strengthen primary healthcare in order for us to achieve universal health coverage in Bayelsa State? Dr. Abe, thank you.
Thank you very much. Just the last one. UNICEF helps to build state structures. And that is also why when we send funds to states, funds are sent to the states. And it's the states that manages the fund. The only thing is there is more like an agreement between UNICEF and the state on what is going to be done. But who manages it is not UNICEF. So in that way, it is our way of helping to build and strengthen the state structures. Having said that, whatever is done for primary health care and to make universal access to health possible in Bayelsa states, one thing is key. The states must be on the driver's seats. You know, partners come and go. My chief here said that they are there's a word you use. Something and go. There's a word you use. They eat and go, yes. Partners come and go. Fortunately for states, UNICEF and WHO seems to be stuck with all the states. So, but there are partners that will come based on their interests, and they will come based on how they perceive the states. So you want to be supported, you must show that the state is willing to be supported by putting their own money on the ground. You know, if we say Bayelsa has very low coverage of immunization, right now they are almost the last in the country in terms of routine immunization. What is the state putting on the ground to make that thing rise? It is at that level you get other partners to support. But just leaving and saying that partners to support will not work, because no partner knows your state more than the way you know your state. And the other one I also want to say is, we cannot overemphasize community ownership and participation. We are just talking here. If the community says the health worker in this health center is not coming to work, and they put fire, just fire, and continue to agitate to the Honorable Commissioner that this health worker that has been posted to this community does not come to work, that health worker will not have peace. Either it goes to work or is removed from there. So even like we're talking about sanctions and reward system, is the community that can make it work, make it happen. And then the next thing is, in that wise, we must now strengthen our ward development committees as well as our community development committees. We have done it in Bayelsa State. We have supported the state to establish and also help them to hold some meetings, in the sense that probably the state will take over, but this was never done. And at the time we also did it, there was also a rise in some of those indices. So it is a strategy that the state can use. We can strengthen those committees and see how they can help in harnessing their workforce, make them come to work, make them see their children, make them deliver their women. And that way we're also improving the indices of the state. Thank you.
Thank you very much, Dr. Abe. Thank you very much. Dr. Oteri, sir, you've just heard from Dr. Abe that Bayelsa is first from the bottom. That is not nice to hear. We are not pleased to hear that in immunization. I know immunization, especially for vaccine preventable diseases, the vaccine preventable diseases speak to infant mortality, child mortality, and morbidity indeed. How can we improve on immunization in Bayelsa State? We don't want to be the first from the bottom anymore. What are your final thoughts, sir?
Thank you very much. I think Okay, thank you very much. I think the key thing here is PAC under one roof and accountability. Are the health workers really working in the places where they're supposed to work? They're not working. So if they're not working and you don't hold them accountable, how are you going to get services done? They're not going to get that. So the first thing is this is the first step. Having this health summit is the first step towards whatever we're trying to address, because today or yesterday we're told the situation reports, which were showing the poor indices and it has been mentioned. So this is the first step. We've agreed that we want to get things going. So what are the things that you can do? Partners can support you. PA Center is something that has worked, and that is where everybody is going. We're not doing verticalized program anymore. So let us have the PA Center role. Get your workers, pull your workers, get the exact workers you need. So if you're having manpower shortage, get those ones that need to make you get your work going. Pull them together, pull your resources. Then you have an advantage, you have an opportunity of an MOU being signed with Gavi, which is going to give you some extra fund and leverage on it. So the state should bring their own counterpart fund to make sure that is done. But once that program starts, the state should be at the driver's seat. They're not going to drive it for you. It is, you know your state, you know your head workers, but the key thing is accountability. Then workers reorientation. The workers, at least I've seen the reports from Bayelsa. January it was 23%. February it came to 5.8%, Penta 3. They're not things that anybody wants to hear. But they said it is fun, fun, fun. The workers, are they doing the work as they're supposed to do? They're not. And nobody is holding them accountable. So please, for us to move forward, let us first ensure that we have that accountability framework. When we did Measles campaign in 2017, we agreed that we're going to do this work and we'll do it well.
Thank you, Dr. Seri. Thank you, Dr. Seri. We're running out of time. Your final thoughts, Dr. Dieng, just 1 minute. Bayelsa State, we need help. We need to strengthen our primary health care. In 1 minute, sir, how can you help us do that?
In 1 minute. Thank you very much. My thought goes toward 3 directions. Number 1, you have to develop an equity program. When I say equity program, because I'm still thinking about the 65% of the population living in the rural setting, how to get access to them. Let me give you one tip. The Rwanda.
We just want it in 1 minute.
Yes, it's 1 minute. One tip on the Rwanda area. In terms of supply chain for the Rwanda immunization program, it's a small country, but with more than 1,000 hills, but they carry everything by using drones. You can send some of your people there to learn how it works. Because even for emergency setting, when for obstetric care and all of these things, emergency obstetric care, they are doing that one, it works perfectly, number 1. Number 2, you ask about what to do about the healthcare worker. Let me ask you, what are you doing with the teachers? The education system, the teachers, they are in the villages. What did they do for remaining there? And the healthcare worker, they are not remaining there. Why? Did you answer to that question? Have you created any kind of enabling system, a kind of incentive to retain this healthcare worker there? If you do it, you see people will move, they will go there to salvage the thing. Thank you very much.
Thank you, sir. And Dr. Angus Ikwe, in 30 seconds, your final thoughts.
Okay, I think it's very unfair, but let me just say my final thoughts will be this, that Bayelsa State should understand that one of the key determinants of health outcomes is economy, which is actually not is outside your control, but you're fortunate to probably be, by my assessment, the richest state by earnings per capita. Bayelsa State is probably the richest. So if there's anything Bayelsa State cannot do, then I don't know which state will be able to do it. And so my recommendations, I have over 15 strategies reform strategies that you can adopt, but I'll just mention 3.5. And the first one, like I said earlier, is to expand social health insurance through enforcement of your mandatory health insurance law. Dr. Obikeze has given you ways to go about it. You can also engage the informal sector. You may think it's difficult, but if you think about it, you'll find ways to do it. And then the next one under organization is to implement what we have all been saying, community ownership. I have a problem, okay, with how we look at community ownership. What are we talking about? The National Health Act already provides for community health committee in the line of management of PSC. Sorry, please, it's very, very important. In the line of management of PSC is provided for, but they don't have the authority. Let us give them the authority to be in charge, like board of directors of the primary health center. Don't call them when it's time to cut grass or time to protect the facility. The third one will be to strengthen regulation. Regulation is our problem. Our regulatory agencies are not effective. They are not well funded. The capacity of the heads of those places is also an issue. Okay, so we should also make sure that the processes for regulation are followed with funding. I repeat again that Bayelsa State has the opportunity because they can provide the funding for some of these improvements. And the half one I was talking about is to take advantage of social marketing strategies in addition to your social mobilization that you do.
Thank you so much, Dr. Angus Ipe. We are indeed very grateful. Like I said, we'll continue to consult you. We are going to take a question from the audience.
Thank you. I'll just be taking one question because of time. We don't have that much time. So this question goes to Mrs. Massa. It says, in the establishment of Centric in the state, there's been no impact created in the local governments. More so, no HIV test kits and malaria test kits and drugs for ANC mothers. Why is that so after FHI 360 left? Did you get the question? All right, I'll ask it again. It says, in the establishment of NEMCHIC and CENTRIC in the state, there has been no impact created at the local government level. And it says, there is also no HIV test kits, malaria, or HIV drugs for antenatal mothers. Why is this so after FHI 360 has left? Thank you.
Thank you. That's the only question. Okay. Okay, thank you. The person that asked that question, actually, people will ask, why is it that since 2019 that they set up the centers that the awareness is so low? Actually, in 2019, something happened. We couldn't inaugurate it until late last year. Actually, Bayelsa State Centric was inaugurated in August 2020. You know, with all our COVID-19 and all that. So actually, the takeoff of activities began in earnest from about November. So we will say that in Bayelsa, we're just about 4 months old or so. But we are doing something in the center. You know, we'll be able to establish the NEMCHIC, but orientation is what is left. And it still boils down to funding. It still boils down to funding. But come next week, we are going to establish some of them, the one the funds can carry. We are going to establish them, I think about 5 of them in one cluster. We are planning that because that's the challenge that we'll be having, you know, almost on a daily basis. When we go down to the grassroots, they tell us they are not aware that that is happening. So as a fallout of this summit, I know with the Honorable Commissioner's commitment and all that, we are going to ensure that the NEMCHICs are established and running. Then but for HIV counseling and testing and ANC and all that, you know, just last week, we were discussing in the meeting and we discovered that from reports from most facilities that HIV counseling and testing is not happening because FHI 360 had left. So the logistics group and the service delivery group, we met in this kind of little meeting, and we have come up with a strategy to ensure that those facilities. It has to be phased. We can't do everything at once. And that's why we are asking for stakeholders buy-in and support and all that. So not too far from now, we are believing that most facilities will be able to supply them with the test kits and testing will go on. Thank you.
Thank you, thank you, thank you. You all agree with me that the panelists have indeed done well. Can we give them a round of applause? We also want to thank you, the audience, for sitting and listening. As a matter of fact, we have so many comments and recommendations bordering on legislation and of the funding that will go to the primary healthcare board, bordering on reward and sanction for health workers. But the most interesting one I think is key, I think we should listen to, is a suggestion that LGAs should recruit health workers and train them so that they can go back to the LGAs and serve. That way, there will not be attrition of healthcare workers from the system. Thank you for all your contributions. Thank you for all your questions. God bless you, our panelists. Can we now step down for the group photograph?
Thank you very much. They will now step down and have the group photographs to bring this particular session to a close. And of course, they say anything worth doing is worth doing well. And that, I'm sure, is why they have taken their time to ensure that everything that needs to be done or said have been said. And we have overshot our time by nearly 3 hours. So we are going to make some adjustments. Actually, we were supposed to have gone for our lunch after this presentation, but because of time, one of the plenary sessions were to have this evening has been moved to tomorrow morning. And that means plenary 5, which is on strategies, prospects, and challenges of implementing performance management and quality improvement in health, has been moved to tomorrow morning. But we'll quickly take plenary 6, which is making informed decisions for health, the role of health information systems and research. We'll quickly take that one before we proceed for our lunch, which of course is almost becoming a dinner, which is even better for us. Well, let's please put our hands together for ourselves, please. Put your hands together for yourselves, put your hands together for yourselves. It's not been easy. At this point, I would like to quickly invite the chair for the next session. Distinguished ladies and gentlemen, I'd like to invite to come up stage and take over the proceedings for the next plenary session, Dr. Rotifa Stella of the Department of Community Medicine, Federal Medical Center, Yenagoa. Please, let's put hands together for her. Let's put hands together for Dr. Rotifa Stella of the Department of Community Medicine, Federal Medical Center, Yenagoa, the chair for the very last session for today. The very last session for today. Dr. Rotifa Stella is the chair. And like I earlier told you, she is of the Department of Community Medicine, Federal Medical Center, Yenagoa. Let's please put our hands together for her. She already did a very good job as co-chair. Yeah, she's coming back again. Madam, you're welcome.
I'm back again. I'm back. Yeah, good afternoon, my audience. This afternoon, we'll be looking at making informed decisions for health, the role of health information system and research. And my co-chair for this session is Dr. Abaye. Dr. Abaye. Dr. Abaye, please. And Mrs. Justina Yeri. Dr. Abaye. So we have a number of panelists for this session. We are going to be fast. We understand that people are tired, and it's going to be a business session. The session, Mrs. Co-chair is here, Dr. Abaye. Mrs. Beatrice Olomietie, Director PRS, State Ministry of Health. Mrs. Beatrice Olomietie, please. Professor Kunle Olowu, is she here? I know she's the provost. Provost, ma, is she here? Is somebody representing her? Oh, okay. I know provost is engaged with NUC accreditation of the College of Medicine, so she sent a representative. Mrs. Olomietie, please. Another panelist is my MD himself, Dr. Dennis Alagwa, the Medical Director, Federal Medical Center in Negwa. That's Dr. Dennis Alagwa, Medical Director, Federal Medical Center in Negwa. You're welcome, sir. Mrs. Olomietie, Director, PRS, State Ministry of Health. Emmanuel Abata, National Health Information Officer, Federal Ministry of Health. Mr. Emmanuel Abata, National Health Information Officer, Federal Ministry of Health. Is he around or is he sending a representative? You're welcome, sir. Mr. Emmanuel Abata. And then we have Mr. Njide Undili, Country Director, Farm Access, Nigeria. Mr. Njide Undili, Country Director, Farm Access, Nigeria. Oh, okay. I'm sorry, ma. Mrs. Njide Undili, Country Director. You know, the male have dominated us. You're welcome, ma. You're welcome. And finally, we have Professor Anthony Emeribe, former Executive Secretary, MLSCN. This is the last. Thank you so much. Like I said, the topic for discussion is making informed decisions for health, the role of information systems.
Once again, you're all welcome to this section of plenary 6, and we will be discussing making informed decisions for health, the role of health information systems and research. So right away, we'll go straight to the discussants, distinguished discussants here, and we'll be discussing with them in the various areas of concern. So permit me to start with Mrs. Beatrice Olomietie, the Director of Health Planning, Research and Statistics, Bayelsa State Ministry of Health. Please, Mark, could you share with us from your wealth of experience how the health management information system in the state has been managed so far. Thank you.
On. Okay. Good evening, everybody. And all the protocol duly observed. The HMI division is in the PRS unit. It is an integrated system that is used in the ministry, and also the partners are also making use of it, and other stakeholders for data collection in the state. The collection method of which we are using is that at the end of the month, the facilities normally have what we call data, what we call tools that they use. Before, we were using the version 2013, and we have registers up to about 15, ranging from the OPD register, family planning register, general attendance register, antenatal register, and so forth. So at the end of the month, the facility M&E goes round and collects this data in the registers and assemble them in one place in his own office. And then he now pick all the information and put them into the monthly summary form. And by the 1st of the month to the 5th, is expected to have completed his job so that he will now give to his subordinate, which is his in charge or the superior officer, maybe the medical doctor that is there, will now also validate this. And after that, it will now be sent to the LGM&E himself too will also now look at this data, also validate it, look at where there are discrepancies and anything, correct them, and at the end, now send it into the DHI through their laptop. So, and he does that before 14th midnight. If he has not done that, he's not reporting on time again. And after that, the reporting time limit is now stopped for on time, but he still has 3 months to still to complete his data before the DHIs will be blocked for that month. So if he does that, after the time limit, he now still goes back to the facility that he has not collected from and make all those collections. And at the end of the 3 months, he enters all his data so that he can have what is being completed.
Thank you very much, ma'am. You still want to make more contributions?
Yes. This is just the structure of how it goes. We still have so much to be said about it. Okay. So after that, like we now have another, which is called they can also have their reports. Because if they don't do this, all what we're doing here cannot come up because we need data in the state. We don't just sit down and we talk and these data are not being reported. Thank you very much.
Thank
So
you
that I don't
very
take
much.
much of your time.
It's because we are running out of time. MD, sir, with your vast experience as the medical director of a federal tertiary hospital, can you tell us in your own thoughts on the role of health information systems and research in making informed decisions for health?
Hello? Health information system has been old as long as medicine was founded. But currently, what we have is a specialized system designed to manage health data by gathering data, analyzing data, storing data, protecting, disseminating data, and using data to make informed decisions and hospital policies. As a medical director, we have tried as much as possible to convert all our folders to electronic medical record system. And has helped us to track patients. Though some of them are also in the course of the seeing them, some of them have scorned. We're able to track them because we have adequate records. It has also helped us to ensure that we're able to look at their data, disseminate information from the patient's file to various relevant consultants that might need to assess those data. In those data, we have comprehensive packages where we have both their diagnosis and also their lab results. So it has helped us in direction of disseminating information to the various consultants that manage them. And if also they need to transfer to any other hospital, we have a comprehensive package where with shortest possible information, we can gather that data and give them those records that they will now use to go to the hospitals where they would need a further management. It has helped us as an institution to form an analysis from the data we have collected from our many times we have seen the research I was able to see in the hospital is about 75 to 80%. While the patients also believe that the doctors are taking care of them, from the research we have done, because we did some research on patient perception, they believe the doctors are very knowledgeable in terms of the information they have. But we also saw that our waiting time was quite long from the research we had done. If we didn't have those patient information and feedback, we may not be able to now assess those levels of information. So I believe that health information system has helped us in several areas. But my own focus and the area I have enjoyed health information system, apart from the medical records, is the area of research. A lot of areas of research, like, let me just maybe 1 minute. I was going through cancers in Nigeria, also cancers in Bayelsa State. I discovered that the commonest cancer, of course, across the country is breast cancer, cervical cancer, prostate cancer, but I can tell you that the prevalence in the state is low. Otherwise, you will not know that. You would think cervical cancer is quite high.
The prevalence of cervical cancer across the country is 9.7%, but in Bayelsa State is 1.25%. That is because of health information systems that have helped us to access those informations. Thank you.
Thank you very much. We really appreciate that contribution. Permit me to invite Dr. Emmanuel Abata to give us his insights in this regard. How has health information system been used, and what specifically right now, what are the key lessons from the national experience that you would like to share with us in 2 minutes, please?
Thank you, Mr. Chairman. Like the last speaker said, decision making using information started in medicine right from the onset. And when we talk about health information system or the information, we just think that it's information, the data. It started in medicine when people were looking for evidence to manage patients. You need the best method. What is the best applicable method to manage patients? And that was how we started using evidence-based, which therapy is working better, which management strategies is better for to improve patient. It was not, the decision then was within the clinical setting. But as time goes on and research comes in, we begin to realize that we can improve on the information use. And that is where we began to expand. But the main mistake people make is when we hear health information system, you think it's only the data, and that is why data has been relegated to the use of, to the record officers in the hospital. And who feels this is the job of the record officer, it's not anybody's job. But the purpose of decision, the first point of decision is within the clinical setting where this data is generated. What is the best way to improve patients' well-being and improve quality of care? Now, as we have gone on, in the national level, like where I am, the experience we've had so far is in terms of understanding. When we say health management information system, we think it's just the register. We think it's just the number we want to collect. And that is why we have not cared on how we collect the numbers. So what is, we felt, oh, this is the job of record officers, so let them give them, officers, okay, let me give them what they want. So every month we want data. Every presentation here has said something about data, but nobody has said something on the issues with data. Why are we not getting this data? Data is not available, is poor, is not, we are not getting it. Why? The data is there, but the problem is, why are we not picking them? Because what data you are looking for is service delivery. If you say there is no data, it means that service has not been provided. And you need to accept that. If you are saying, oh, we don't have data for the state, it means you are saying, in our state, we are not providing data. We are not providing services. Because data is just documenting, and we call it, we define data as a bridge version of the guideline. It's a clinical procedure that you are picking, you are documenting. And that is why most times, if you don't really understand the system that is called health management information system, I see health management of information system as another building block inside the health system building block, because it has all the components of the health building blocks. You need human resources, you need governance to make decisions, maybe to make policies, and the rest of them. So my experience as a national health management information, head of health management information, I have done this for 20 years, and this Bayelsa, I was one of those that established HIV clinics in this Bayelsa. We did all the assessment, I will tell you that the problem here is issue of investment. You cannot be expecting to reap from where you have not planted. People are not investing in health management information system. Right now, we have large partners are here and there. FHI, I just like the last presentation, FHI left the place, and there is issue of HIV test kit shortage. It means we are not prepared. If one of the things I tell them, this madam used to attend my meeting, I tell you, whenever you expect partners to fund you, partners are businessmen, and they will definitely live. Once they get what they want, a partner in your habitation is like a man, you have a very beautiful wife, and your neighbor, most times you don't leave money with you in your house, your neighbor is providing for you. One day you will meet your neighbor inside your bedroom, and there is nothing you will do about it. Most of the partners are businessmen. The Honorable Commissioner said yesterday, I think yesterday or today, that, well, we are likely to be like Solomon, that have many wives very soon. But what he never mentioned was that Solomon with many wives, who lost his kingdom because he built only one temple and 1,000 shrines. Partners that we have, if you are not putting the investment yourself, most partners are here for business, they will not help your system. If you want a vibrant health management information system, you need to analyze what are the components and what are the weaknesses that we require to build a functional health management information system. And if you have a functional health management system, you will be able to take decisions on your health system. You cannot do without data. Data is the next crude oil. And we know that there are
Thank you, sir. Thank you, sir. We appreciate your contribution. Thank you so much. Yes, Mrs. Njide Ndidi, you are the country director of Farm Access Nigeria. And I know we can't talk about a data information system without talking about pharmacoepidemiology, pharmacovigilance, and all of that. You have all the information. Please, can you share your thoughts on the role of health information system in making informed decisions for health? Thank you. In 2 minutes, ma'am.
In 2 minutes.
Yes, ma'am.
It's hard. In fact, I was going to say that somehow we've left the most critical segment for last. There is no way, just following up from where he started, there's no way to improve something that you cannot measure. And the only way to measure the outcomes or the input you're putting into a system is by data collection. First of all, just a point of correction, Farm Access Foundation is actually not a pharmaceutical company. We are the first NGO that started the mandatory, voluntary health insurance scheme in Kwara State many, many years ago. It's based on our project, a pilot project, which was to test the paradigm, whether people will buy health insurance or pay for it voluntarily if they appreciate the quality of care that they're receiving. We subsidized the premium, we improved the supply side, but most importantly, we did an impact evaluation in partnership with Amsterdam Institute of Global Health. We took the results, data collected over so many years. In fact, there are over 10 PhDs on that project. We took that data, partnered with World Bank Health in Africa Initiative. And that has been the catalyst. When you talk about 36 states in Nigeria having mandatory health insurance laws, is as a result of the Kwara Health Insurance Scheme. You can go look it up. So in any case, what I'm trying to say is that it is so critical. That is, the importance of data cannot be overemphasized. And you can look at it on so many levels. On one level is the demand side. All of you have mobile phones. Mobile phones should be the next aggregator. If you go and look at what is happening with MTBA in Kenya, it will give you the power of the mobile phone and how you can use that to aggregate funding, be it insurance, be it in somebody giving you money and so on and so forth. There are 177 million active phone lines in Nigeria. So on that one side, there's a lot of data. And yesterday, somebody mentioned that, the multinationals came in and focused their marketing strategy on the poor. I can tell you that MTN's biggest income driver, Naira a month. It's not the people spending 5,000, it's not that are spending less than 100 Naira a month is the biggest margin. So they're milking that data. If you look at the supply side, which is the hospital, I'll give you the example of FMC Ebutemeta. Most of you must have heard of it. If you haven't, go and look at them. We were the ones that supported them. All they did was digitize their patient records, their inventory, cashless system, as well as their record management. And you can see the transformation. Up till now, in fact, he's not looking for a location. He has plugged the leakage within the facility. He's using the extra cash to upgrade his on and on. But thank you. The bottom line is that without that, you cannot begin to strengthen your health system. So what is the minimum a viable product that you can put in to be able to get that data to improve your system?
Thank you very much. Now, finally, well, Professor Anthony Eberibe, your thoughts in 2 minutes, and 2 minutes, 2 minutes, Prof. Thank you. On the role of health information system and research in making informed decisions. 2 minutes, Prof.
Yeah, thank you very much. WHO just recently, only 2020, reaffirmed that the only way to have reasonable level of cutting down on disease burden, particularly in endemic areas, is through functional research. It is only through research that you can now talk about having proper design and ways to manage diseases. And how do you talk about research in a multi-sectoral system like health without collaboration is the key thing. When we talk about partnership, we look at different agencies coming together. When we talk about research, which is the key to making a reasonable change in disease management and control, we talk about different groups of professionals coming together, different groups of stakeholders within the core health and outside the core health system coming together. And if they have the principles of team play is important. Mutual respect, shared responsibility in terms of taking the glory in succeeding or the shame in failing. If they know there is what happens with the project, they have shared vision. They have to have definitive timeline for capacity training and building up for all members of the team. In this day and age, research is not what many of us in the university system or academic system, we are used to seeing it as publish and perish without looking at the impact of the research. In this day and age, multiple authorship is the thing. Multiple centers being involved, multiple individual researchers coming together and having a shared vision of that project. As I said before, with common understanding of what it's all about. Research is not just about, as I said before, not just publishing, but making informed decisions in improving the state of our healthcare industry. It doesn't matter whether it's at the primary healthcare center or the tertiary healthcare center. There is a difference between retroactive research, which some of us talk about, we'll talk about the usual health information management system data you get from there, which we call operational research. From prospective research based on specified targets to solve a particular need prospectively. Both of them are important. Both the one we get from the data we already have, and we have a lot of data. And a good chunk of this data really comes from the laboratory. But unfortunately, the laboratory is often neglected. We have tons and tons of data, both from the primary health center, lab services, secondary, tertiary, and quaternary, which are hardly used.
more often than not, if we don't get the policymakers properly have the data presented to them, they will not understand the need. I must talk about the area of quality. It doesn't matter the kind of data we have. If we don't tune the data towards, we are failing. At quality, we're talking about turnaround time. We are talking about efficiency. We are talking about effectiveness. We are talking about satisfaction of the client and all that. They all come together so that we don't work from answer to question. We set out from the beginning as to what we want and then get it structured properly in designing. Thank you.
Thank you very much, Prof. Please, as we take our final parting thoughts, then from the audience, if we can just have your questions and comments submitted to our partner. Yes, she's collecting it. So we'll take one question at the end. So take the parting shots.
All right. Thank you very much. I'd like to start with Dr. Dennis Alagwa, the MD of Federal Medical Center in Ecuador. What areas of collaboration would you like to see in the area of health information management, and especially as it affects research in FMC Yenegua? In 1 minute, sir.
Thank you, Mr. Moderator. The world is a global village, and the direction of medical care now is health information system or health information management. Like I said earlier, we have moved from electronic medical records, and we're going to health officials having their own computers. And with those computers, they can now see their patients and secure their data. And we need support in that direction because it's very, very cost intensive. We have saved lots of money, like the other speaker talked about, Butemeta. We have saved a lot of money because now we are cashless. You cannot go to the center and pay any money, and leakages have been blocked. We have gotten lots of information. I will end with one. From the data we have collected, we found out that one, this COVID-19 vaccination hesitancy will be there. Because in the data we collected before this time, the publication we had done, that 22.7% of patients that we saw, we asked them, will you be willing to take the vaccine? They said no. We said why? They said they don't trust the government, they don't trust the vaccine. And it played out when we began the AstraZeneca vaccination. I don't know if I have 1 moment, I just want to say one more thing. We discovered also we are having increased cesarean section rates from our data. And we are wondering why. We found out that 80% of those patients that made up that amount of that 42% of people having cesarean section, we are from unbooked patients. We knew that our efforts in carrying out antenatal care was not good enough. And we, as a policymaker, we felt it's a direction to look at. So we would like partners in terms of providing infrastructure for us, and also
support.
Hello?
Infrastructure and equipment.
Yes, to enable us to do more, so policy in the right direction.
Thank you very much. Thank you. May I go on to Lomiete? In a minute, please just tell us one thing you would do differently. In this conference, a lot of issues about collaboration and doing new things or doing things differently have been raised. Tell us one thing you would like to do differently to improve on some of the gaps that you've already identified in your HMIS and research work. Yeah. What would you like to do differently in a minute?
Thank you. From the health management information system, one of the things I think that we use to help to improve our data in our system here is that our M&E officers that are all here, they have 1 or 2 challenges with them. And we think that if laptops and funds are being released for them for their data collection regularly, with their support and and giving them money for data, which they will be collecting data, most times we will not have problems from them. At every point in time, they will do that, and at the end of the day, they will still come back again to their facility, where in the LT also, where they can now sit down, and at the end of the day, they will analyze this data and see where their discrepancies is and set them up, so that in future, we will not have any problem in our data reporting. Thank you.
Thank you very much, Mrs. Onomieke. Yes, Mr. Emmanuel Abata, you're very experienced and you're a very experienced information officer. Just in 1 minute, sir, tell us what we have to do differently in Bayelsa State to use our health information to move the state forward in 1 minute.
Okay, thank you, Ma. Based on my experience in Bayelsa, one of the problems we have found here is inadequate funding for health management information system. Right now, there's not much investment in terms of its capacity, infrastructures, and skills. You need to invest heavily in all these areas for you to be able to get information you can use to make decisions. If you don't invest, I'll tell you, you will not make a decision that will lead you to your dreams. Because it's not just getting data to make decisions, it's getting the right data, the quality data for decision making. And for you to get that right data, you need the investment. You need to assess your system to know the weaknesses of the health information system. Right now, we are operating hybrid platform where we have paper-based and electronic-based system. The way we are going globally is we have found out people are leveraging on ICT in terms of data, and we cannot run away from investment in ICT, and we think we want to get accurate data, because accurate ICT will help us to track both not only in data alone, it will help us to track logistics, even all these finances. ICT will help us measure the investment. How much have we put in? What is the impact of our investment? Where have we done well? Where do we need to put more investment? So if we are not investing in health management information system, and we depend, because what we are doing right now is donor dependent, and once the donor leaves, everything goes down. If we depend on donor continually, we are not to get the best out of the system. Our decisions will not be the right decision. I tell you, in the next 10 years, we are still discussing the same thing. This is the time to do the right thing. Thank you very much.
Thank you very much. He has told us about donor dependence and donor fatigue, and then the need for Bayelsa to invest in ICT. Now, in 1 minute, and 1 minute is 1 minute. Your thoughts, ma'am?
Well, I think what I have to say is that we need to go back and understand what is required. And in your vocabulary, you need to look at where you are in terms of digitization. So a lot of systems are either manual, but we need to transition to digitalization, which is where you convert the processes within your facility or your establishment into a digital process. Then the next one is digitalization, which is when you now integrate with other stakeholders within the industry. Then the final part, which we are not there yet, is digital transformation, and that is when the patient is in the center and controlling. I own my medical records and I allow people to do that. So we still have a long way to go. Most of us are still manual, but that is where we need to start. Convert your manual processes into digital processes, digital, and head towards digital transformation.
Thank you very much. We're also talking ICT here. Finally, Prof, in 1 minute, tell us what we should be doing differently in 1 minute.
Thank you very much. What we need to do differently is to take seriously the area of research. operational research. And when we talk about that, we talk about laboratories. If we don't have quality and functional health lab services, we have missed it. You know that about 70 to 80% of is required for effective healthcare planning and management come from the laboratory. And yet, when it comes to budgeting, only about 5% of the money goes to the laboratory. And again, more importantly, why you have to take that seriously. Honorable Commissioner, I would like you to think about having a legislation for laboratory revolving fund. That is the gold mine in the healthcare industry. But we don't take it seriously. If we have a good medical laboratory services revolving fund, the CMD here will appreciate what I'm trying to say. You find out that that is one area you can have funding to be able to do some of these things we're talking about, and then have ownership and sustainability of the programs. Looking inwardly, I'm talking about. I don't want to talk about external funding. And if you get your lab services properly done, you can even have companies coming for drug trials, depending on your lab services, once they are certified and accredited, which we take for granted in Nigeria. Thank you very much.
Thank you very much, Prof. He has told us about research. And of course, research is the key. And research funding laboratory, yeah. So we would like to get 2 questions from the audience, straight to the point.
Thank you, the chair. Thank you, the panelists, for this opportunity. Thank you so much. And now the questions are we have it directed to Madam Beatrice. It says, how do we intend to establish improved and better health information management system when the key actors and players in health information management system are salvaged with untrained presence, like monitoring and evaluation officers, M&E, at the LGA? That's number 1 question. How do information management system, that's what it's saying. Now we have the second question.
So, Mrs. Olomite, the question is, the people handling the health information system in Bayelsa State are untrained. And the question also is, how are you going to use untrained personnel to achieve success in health information system? Thank you.
Thank you for giving us this question. The people that are saying that health information management people are untrained, I don't think they're really telling us the truth. Of recent, last year, I think September, October, December, we had Yenegua LGA and Kolokma LGA trained on the new data tools, version 2019. Just this year, I now had to train another batch of the LGA MIE workers, 2 per facility that have been trained. So I don't know where they are being saying that they are being untrained. And again, I said, like when I was even talking, I said that 5 of these LGAs has been trained, 3 LGAs has not been trained on the new data tools. The old data tools, which was version 2013, everybody has been trained. But we have moved from version 2013. Now we are on version 2019, okay? And we have trained 5 LGAs in the state, so remaining 3 LGAs. And I hope that immediately after this summit, we will still send our applications again to the Honorable Commissioner. And I hope that funds will be released and where these LGAs will also be trained, and we will not hear that any person has not been trained. 2 persons per facility has been trained, and I think we have trained about 70% of the state on the new data tools.
Okay, thank you very much. You said 2 persons per facility have been trained. It could be that the problem is that those who have been trained have not cascaded their training. Persons. When you train them, please, it should be training of trainers. They should cascade their training so that the least person, the smallest person, the youngest person in that information system knows what the most senior person knows. The problem with training in this environment is that when people are trained, they don't cascade. And the senior people are not the ones that do the work. So when the senior people don't do the work, the people who actually do the work, training should be cascaded to them. Thank you. What's the next question?
Madam, please. This particular I'm even talking about, the LGM&E officers can testify to me that they are the ones that even brought up the list of the people that were going to be trained, because I told them those places in the facility that are really doing the work are the ones that I want to see. And I know a lot of them have also been trained and retrained before. And they also have phones that we have been using. I also checked my list and I saw that these are the people that have been using this data and working for all this while. So just like I said, the three remaining facilities, three remaining LGAs, we hope to train them. The data tools also have been circulated to all the LGAs.
Thank you very much.
Thank
you very much. The next question.
The next question is, can you please kindly throw more light on the role of health information management? Who are the health information management system providers?
Who are?
The health information management system providers.
I can't do it. Okay, the health information system providers.
Yes. Excuse me, ma'am. 1 minute. You know that the health information officers here, okay, they've been complaining because their numbers are not enough. For that reason, there are other health workers in the facility.
Okay, we step down the question. I was asking them. What's the question, please?
The comment.
Comment.
Yes.
Then the
Can I just go
comment.
ahead?
Well.
In strengthening the HIS to provide evidence for planning, clinical decision, resource allocation, etc., consideration should be made in 1, identifying data needs and how data will be collected. The state's strategic health development plan will throw light on this. Second, he said, drivers for data, this should be the highest decision-making body in the state, such as the Health Council on Health. The third one is having two above will help in establishing sustainable resources for the HIS. Think about data representation, knowledge management and action, and accountability framework that tracks intervention and funding. Thank you.
Thank you very much for the comments. Please pardon us, we really must round up at this moment, but let's just please recognize the presence of the representative, Professor Olowu, who is still here with us. Recognize him. We are rounding up Professor Y.M. Tafeng. At the end of this discussion. So once again, discussants, we appreciate your contribution. We appreciate your experience sharing. And I believe that in this conference, we are gaining a lot of insights as to how we can improve our health system. And I believe that Bayelsa health system will not remain the same after this summit. Thank you.
This is to thank the audience for your patience. You've been here since morning. We cannot appreciate you enough. We are very grateful for your patience, for taking time to listen to all of this. Bayelsa healthcare system is surely going to improve. Thank you very much. Thank you.
Distinguished ladies and gentlemen, we'll go for lunch. Remember, just the is lunch dinner. The panelists, please, are going to the first hall. The panelists and the local organizing committee, please go to the first hall. If you have your meal ticket, if you don't have and you're a panelist, please, you can indicate, we'll get a meal ticket to you. Upstairs is for the rest of the participants and outside also. And the poster presentation will be done tomorrow morning.
Please, we have a lost and found shade. If you know your sunshade is missing, please come to the technical team to collect your shade. Lost and found sunshade.
I can advise. I can have the best night of my think I'd leave your side, babe.